opening statement, he will be joined by Dr. Jessica Banton and Dr. Jeffrey Kling. Dr. Banton is the Deputy Assistant Director for Health, Retirement, and Long-Term Care Analysis at the CBO, and Dr. Kling is the Associate Director for Economic Analysis at the Congressional Budget Office. Members may direct their questions to any of the three witnesses. Now I yield myself 5 minutes for the opening statement. Once again, I'd like to welcome our witnesses from the Congressional Budget Office. Thank you for joining us. I appreciate the opportunity to dive into your recent report on single-payer healthcare systems. Ensuring access to quality, affordable healthcare remains one of the greatest policy challenges of our time. The Affordable Care Act has given us a great foundation on which to build. Since it was enacted, 20 million more Americans have been able to gain meaningful health coverage. Currently, 89% of Americans under 65 are insured, and that's an historic high. But even with these dramatic gains, 30 million Americans still live without health insurance. And even for those Americans with health insurance, many are underinsured and still struggle with high deductibles and copays. Too many American families still must make the impossible choice between going to the doctor or putting food on their table, filling their gas tank or refilling a prescription. We cannot accept this tragic reality as the status quo. Progress must produce more progress, and we must begin to pursue the next wave of healthcare reforms. That's why last summer I promised that if I became chairman of the Budget Committee, we would hold a hearing on single-payer healthcare. In January, I requested a CBO report on key policy considerations to lay the groundwork for advancing legislation to expand quality and affordable health coverage. Earlier this month, CBO released this report, and today we will examine its findings. My goal for this hearing is to work through some of the policy issues laid out in this report, including what eligibility would look like and what benefits could be covered, how the system could be financed, how a single-payer system might affect the price of prescription drugs, what kind of transition period would be needed to allow healthcare providers and other stakeholders time to prepare. Major reforms like the ones outlined in this report would mean major consequences for the health of our citizens as well as the health of our economy. They must be done carefully and methodically, but not without urgency. Access to affordable health care isn't just a policy proposal or a political slogan, it's life or death for millions of Americans. I also hope to review what we as a country spend on health care now and what we get in return, as well as our long-term fiscal outlook with or without major reforms. Last year, health spending accounted for 18% of our economy. We spend upwards of $3.5 trillion annually as a nation on health care, more per person than any other country. And yet our outcomes are some of the worst among developed nations. Our wasteful and inefficient system has led to skyrocketing prescription drug prices and out-of-pocket costs for consumers, all while insurance companies and CEOs continue to post massive profits. A single-payer system could expand access to care, decrease our nation's total health care spending, and help grow our economy. The trick is closing the information gap on what single-payer health care truly is so that we can close the health coverage gap for millions of American families. I know that the advocates here today and across the country have been at the front lines of this fight for years, and I want to thank you for that hard work and dedication. I've also talked to small business owners and numerous CEOs of Fortune 500 companies. They privately tell me they are all for a single-payer system. They know we are the only country that provides health care the way we do. Last year, the average U.S. employer spent more than $5,700 for a single employee plan and more than $14,000 for a family health plan. These CEOs know that a system of employer-based coverage puts them at a disadvantage with their global competitors. There's a consensus among economists that our system of employer-based coverage displaces wages, relieving employers from the burden of providing coverage will empower American companies to raise employee wages, expand their businesses, and help to grow our nation's economy. Given all these reasons, it is incumbent upon us to begin to work through the opportunities and trade-offs involved in a single-payer system, as well as other ways to achieve universal coverage, many of which have been proposed by members of this committee. I strongly believe it's not a matter of if we will have universal coverage, but when. The CBO report and this subsequent hearing are designed to advance that timeline. Before I close, I would like to request unanimous consent to submit materials from the American Academy of Actuaries, American Hospital Association, Health Over Profit for Everyone, Healthcare Leadership Council, National Association of Health Underwriters, National Nurses United, Partnership for Employer-Sponsored Coverage, and Public Citizen in the hearing record. Without objections, so ordered. I thank our witnesses once again for helping us with this important discussion, and I look forward to your testimony. I now yield 5 minutes to the ranking member, Mr. Womack, for his opening statement.
I thank the chairman, and good morning, everyone. Chairman Yarmouth, thank you for scheduling this hearing today. If I read Politico correctly, I understand that there's a chance we can have another hearing on the Jayapal proposal, which I certainly would look forward to, and hopefully we can make that happen. Deputy Director Mark Hadley, welcome, and to the other two witnesses, thank you for your team here being here today. We're here to discuss a sobering report developed by CBO at the request of our chairman that details some of the risks of imposing a one-size-fits-all government-run healthcare system, as proposals like Medicare for All would do. What's noticeably missing from the report is a cost estimate for specific proposals. My friends across the aisle didn't ask for one. I think I know why. While the score would be useful, we already know how much a one-size-fits-all healthcare system would cost the American people. Independent analyses from economists across the ideological spectrum, including George Mason University, the Urban Institute, the American Action Forum, have projected single-payer type proposals, such as Medicare for All, to cost at least $32 trillion. That number bears repeating, $32 trillion, on top of what we're already spending on health care. That's at least $10 trillion more than our nation's astronomically high $22 trillion debt. That's roughly $10,000 per every American per year and is equivalent to 11% of GDP each year. CBO states very clearly in its report that government spending on health care would increase substantially under a single-payer system. How could the federal government pay for these substantial spending increases? Well, the report outlines 4 methods. The government could impose tax hikes. It could increase premiums. It could rely more heavily on cost sharing, which is another way of saying out-of-pocket costs such as copays. Or it could just add this enormous price tag to our existing debt without any pay-fors at all. My guess is all of the above. Now, if you're someone who subscribes to the modern monetary theory, maybe the debt doesn't matter to you. That's, of course, not the way I see it. Putting aside discussions about how to finance such a costly proposal, this report has been especially helpful in showing that these ideas will never work in America. Imposing a single-payer healthcare system would eliminate private insurance. That includes the health care 158 million Americans receive through their employer or their union. The CBO report even warns that under this type of system, patients would not have a choice of insurer or health benefits, and the public plan might not address the needs of some people. Further, the CBO report also explicitly points out the broader impact the proposal could have on health care. For example, by reducing payment rates for providers, that is, payments for doctors, hospitals, and so on. The report explains there will not only be a reduction in the quality of care, there would be a reduction in the supply of care, hampering access to the treatments and services people need. It's clear proposals like Medicare for All will chase a lot of doctors out of health care. That's not only my strong opinion, it's backed up by hard facts. These are just a few of the findings from the CBO report, and I expect to discuss many more with our witnesses today. I hope my colleagues and the public will listen carefully. The consequences of what health care could become under a Democrat-controlled government will be articulated very clearly here today. With that in mind, I urge all my colleagues not to look at this report in isolation, but rather to look at this report in the context of existing proposals, including the Medicare for All Act of 2019. Toward that end, when considering other proposals, the other side admits that more limited expansions of existing federal programs, a Medicare buy-in or a Medicaid buy-in, for example, are in fact a step towards single-payer government-run health care. They admit this openly. This is the direction some lawmakers want to take your health care, and it will have consequences that ripple through the most personal aspects of American life, from fewer doctors and longer wait times to less access and no choices. That's why this conversation today is so important. Before I conclude, I'd like to ask for unanimous consent to enter into the record the 3 studies I mentioned earlier from George Mason University, the Urban Institute, and the American Action Forum. Additionally, I'd like to seek unanimous consent to enter into the record a study of the impact of single-payer proposals on our nation's hospitals.
Without objection.
And with that, Mr. Chairman, I yield back.
I thank the gentleman for his opening statement. In the interest of time, if any other members have opening statements, you may submit those statements in writing for the record. I'd like to thank our witnesses for being here this morning. Mr. Hadley, the committee has received a written statement and it will be made part of the formal hearing record. You will have 10 minutes to deliver your oral remarks. You may begin when you are ready.
Chairman Yarmouth, Ranking Member Womack, and members of the committee, thank you for inviting me and my colleagues to come and testify today about the Congressional Budget Office's recent work on single-payer healthcare systems. Some members of Congress have proposed establishing a single-payer healthcare system in the United States. Many more people would probably have health insurance as a result, but the government would take much more control over the healthcare system. The effects of such a system on its participants and total healthcare spending could vary greatly depending on the details of the system's structure and operation. Earlier this month, Cbo released a report on single-payer healthcare systems. That report describes the primary features of single-payer healthcare systems and discusses some of the considerations for establishing such a system in the United States. It represents our first step in a broader effort to support you as you consider the issue and build our capacity to estimate the cost of specific proposals. I want to convey two main points this morning. First, moving to a single-payer system would be a major undertaking. It would involve significant changes for all participants: individuals, providers, insurers, employers, and manufacturers of drugs and medical devices. Because healthcare spending currently accounts for 1/6 of the nation's economic activity, those changes could significantly affect the overall U.S. economy, and the transition toward a single-payer system could be complicated, challenging, and potentially disruptive. Second, to establish a single-payer system, lawmakers would need to make many decisions and would face complex trade-offs. The first figure in our report, which you have in front of you as a handout, identifies some of the major questions that would need to be answered. With the balance of my time, I will focus on 3 sets of issues that illustrate the complexities involved in designing a single-payer system. The first set of issues relates to coverage. In a single-payer system that achieved universal coverage, everyone eligible would receive health insurance coverage with a specified set of benefits regardless of their health status. People who currently have private insurance would enroll in a public plan. Under the current system, an average of 30 million people per month are projected to be uninsured in 2019. Most of those people are U.S. citizens and would be covered by a public plan under a single-payer system. Policymakers would have a lot of choices to make about how to extend coverage, particularly if each state administered a separate plan. One of those choices would be whether non-citizens who are not lawfully present would be eligible, 11 million people in 2019, and about half of them have insurance under the current system. The second set of issues relates to costs. Under a single-payer system, the government, federal or state, would pay a larger share of all national healthcare costs. In 2017, private sources, such as businesses and households, contributed just under half of the $3.5 trillion of total national healthcare spending. Shifting such a large amount of expenditures from private to public sources would significantly increase government spending and would require substantial additional government resources. Total national healthcare spending on a single-payer system might be more or less than it is under the current system, depending on key features of the new system, including the services covered, patients' cost-sharing requirements, provider payment rates, and administrative costs. And I'll turn to each of those briefly. The benefit package could be designed to cover services that are typically covered by private insurance and Medicare. Alternatively, it could be expanded to cover additional services, such as dental, vision, hearing, or long-term services and supports. Expanding the benefit package to cover additional services would tend to increase healthcare spending. Cost sharing affects beneficiaries' financial well-being and total healthcare spending. People use more care when their cost is lower, so having a lower or no cost-sharing requirement would tend to increase the use of services and lead to additional healthcare spending. Under a single-payer system, Provider payment rates could be based on rates paid by Medicare, Medicaid, commercial insurance, or some other measure. Medicare payment rates are substantially lower than commercial payment rates on average. If provider payment rates were set at Medicare's rates rather than average commercial rates, then total national healthcare spending would be lower. But the amount of care supplied and the quality of that care might diminish. When fully implemented, a single-payer system would probably have lower administrative costs than the current system because it would consolidate administrative tasks and eliminate insurer profits. To give a sense of scale, the federal government's cost of administering the Medicare program accounted for 1.4% of total Medicare expenditures in 2017. When you include the costs of the administrative costs of Medicare Advantage and Part D plans, total administrative costs for the Medicare program accounted for about 6% of its expenditures. By comparison, private insurers' administrative costs average about 12% in 2017. But other possible features of a single-payer system, including efforts to coordinate patient care and eliminate fraudulent spending, could add administrative costs. A single-payer system could affect the cost to providers and individuals in other ways. It could reduce the amount of uncompensated care, for example, and unlike private insurers, which can experience substantial enrollee turnover, a single-payer system would have no turnover. For that reason, a single-payer system would have a greater incentive to invest in preventative measures that have been shown to reduce costs. Whether the system would act on that incentive is unknown. The final set of issues relates to people's access to health care. An expansion of insurance coverage under a single-payer system would help more people receive more health care. People who are currently uninsured would receive coverage, and some people who already have coverage would use additional services, particularly if those had lower out-of-pocket costs. Whether the supply of providers would be adequate to meet the greater demand would depend on various components of the system. If the supply of services was not sufficient to meet the demand for care, patients would face increased wait times and reduced access to care. The government, however, could implement policies to encourage the provision of services, and in the longer run, providers might deliver more care more efficiently. Under a single-payer system, people who are currently covered by private insurance might have more providers available to choose from. Participants would not have a choice of insurer or health benefits, however. The public plan would provide the same set of healthcare services to everyone eligible, so it might not address the needs of some people. For example, the public plan might not be as quick to cover new treatments and new technologies as would a system of competing private insurers. Policymakers could try to design the single-payer system to mitigate such risks. As I said at the start of my testimony, CBO has worked to build our capacity to support this committee and the Congress as you consider these issues. We look forward to being helpful to you and your staff. My colleagues and I are happy to answer your questions. Thank you.
Thank you, Mr. Hadley. I appreciate your testimony. And now we begin the question and answer period. And I now recognize the gentlelady from Connecticut, Ms. DeLauro, for 5 minutes.
Thank you very much, Mr. Chairman, and thank our panel and our speaker this morning. I think it's fair to say that the shared goal of my Democratic colleagues on health care is looking at the way in which we achieve universal health coverage in the U.S. Now, we do have several iterations. The one that I've introduced is Medicare for America, which ensures universal, affordable, high-quality health coverage by building both on Medicare and Medicaid, and to expand that covered benefits and services. Under the current system, health care benefits are largely dependent on your zip code, and Medicare, what we try to do is to fix that in this legislation. Universal coverage needs to include long-term services and support because we've got millions of Americans who live with disabilities and those taking care of an aging loved one. So we can't keep long-term services and supports separate from our healthcare system. A third, what we try to do is to achieve the universal coverage through a combination of individuals and employers choosing Medicare for America, auto-enrolling Americans at birth, and the uninsured into Medicare for America and employer-sponsored insurance. We look at trying to bring costs down for families, Premiums cost no more than 8% of individuals' or households' monthly income. There are no deductibles, and it simplifies cost sharing and will in fact bring down costs for families. We ban private contracting, which has created that two-tier system of health care in America. It's one tier for people with health insurance and another for the wealthy who can afford to pay for their care without any insurance. And just a couple of items, student loan forgiveness program. Providers for healthcare providers that accept Medicare for America forgives 10% of student loan debt each year for a healthcare provider or an institution for a provider that accepts Medicare for America payment rates. So we want to make sure that there are healthcare providers. And finally, a workforce development program for individuals who work in-home and community-based long-term services and supports. So we are going to increase the number, or try to increase the number of caregivers to be able to take care of the increasing number of seniors and those disabled. Let me just, going back to benefit design, which is a tremendous concern when you consider any universal coverage plan. If you live in Connecticut or Mississippi, Utah, California, everywhere an American should have comprehensive, affordable health care. Connecticut, our Medicaid program covers things like dental care for adults. Alabama, Texas does not. Missouri, Pennsylvania does not cover physical therapy. Connecticut does. Arkansas covers eyeglasses for adults. California does not. Just correct me if I'm wrong, that a single-payer system that delegates benefit design to the states could lead to inequalities. If this is true, what safeguards need to be put in place to ensure that benefits are standard across the country for all enrollees?
Yes, as we said in the report in the section on administration, one of the key questions is whether this would be administered by the states or the federal government. And there can be lots of variation that policymakers choose from how that would be done. So even if a program were administered by the state level, it could delegate some authority to states to make some decisions. Alternatively, if there was a program administered by the states, the federal government could supervise and highly regulate the benefit design.
Doesn't that, just a final question, because I used my time, but doesn't that continue this patchwork that we have in this country with regard to healthcare services and the inclusion of long-term services of the disabled? I think one of the fundamental problems is that, again, it's your zip code, the determination of what kind of care, what kind of services that you get. Doesn't it make more sense to have something that is uniform and that it is directed centrally?
Well, we don't make policy recommendations, but it is a policy choice for you all to decide whether there would be one uniform set across the country or whether it would be controlled at a more local level.
Okay. Well, I understand that we do make policy, but I'm sure that you've got views and that you, I would have hoped that you might share with us as to how we do get to standardized care for people in this country. But thank you very, very much, Mr. Chairman. I yield back, and I thank you.
I thank the gentlelady. I now yield 5 minutes to the gentleman from Ohio, Mr. Johnson.
Thank you, Mr. Chairman, and I want to thank the panel for joining us today. I appreciate the opportunity to move past the, quote, free health care tagline and talk about the actual reality of implementing Medicare for all. I'm an IT guy, spent 30 years in information technology before coming to Congress. Mr. Hadley, in your report, you describe a standardized IT system that implements portable electronic medical records. So question number one, in the U.S., we have a lot of different health IT systems that would have to be merged together to achieve a standardized system. Would this be similar to what the VA and DOD are trying to do today?
Yes, Congressman, they are trying to create a system so that DOD and VA's medical records can be interoperable, meaning they can be transferred between the two organizations with a minimal amount of transactional work done to interpret them.
So it's a similar process. How many records are being merged in the VA and DOD systems? And if we were to cover every single American under a single-payer IT system, how many records would that be?
I don't have the exact number of the records at VA that are being merged, but if we were covering the entire United States, it would be, the population's 329 million people, substantially more than are covered by the VA and DoD.
Well, I have the number here for you. It's about 18 million records is what the VA and DoD is doing. It's my understanding that since 2011, the VA and DoD have been attempting to merge their electronic health records with a 10-year estimated cost of $16.1 billion. What are some of the challenges a national standardized IT system would face?
Well, I think the key one is going to be interoperability, but there has been an attempt over the last several years to have more providers move to having more electronic medical records, but they sort of diverged into different directions when they did that, and so at the moment, they're having real problems having those systems talk to each other. But
Yeah, I certainly agree with that. Interoperability is rarely thought about up front, and it winds up biting us in the backside at the end. Do you have any idea on cost? I mean, if the VA is spending $16.1 billion over 10 years for 18 million records, you got any idea what a cost of a standardized system to cover everybody in this country would be?
I don't at this time. The kind of the system that you're describing would be similar to the one that is in Taiwan, but there are many countries that don't have a fully developed system that is similar to that one.
Okay, let's talk about security a little bit. You know, if such a system were implemented, would the security of the databases and the networks that house such a system and records, would that be a concern for you?
Yes, absolutely. And I expect the government would invest heavily in trying to protect those systems.
Okay. Is there a precedent for large-scale government data breaches in government-run databases?
Yes, Congressman.
Okay, yeah, because we saw that in 2015, both OPM and VA experienced data breaches, which exposed an estimated 22 million and 26.5 million people's personal data, respectively. Is it necessary for the government to manage all of the electronic health records?
No.
Run a system of this size?
It could be run in different ways. It could be a simpler design of electronic records. So, for example, it could be more like a billing system, such as we see it with Medicare fee-for-service.
Okay. What would happen if there was no central database? You talk about interoperability, and we saw early on in the journey for an electronic health record the lack of interoperability and how that was being such a negative around our healthcare community. Would if there was no central database with all the problems of cost and security and interoperability that we just described, would quality of care decrease in such a system?
Well, so yes, I think you'd be foregoing some of the benefits you might get from such a system, and those would include patient care coordination, but also eliminating duplicative services. You know,
one of the things, and I'll wrap up here, Mr. Chairman, one of the things that is widely known by IT professionals is that the life cycle cost of a system is one number. 75% of that life cycle cost is in operations and maintenance. The easy part, believe it or not, as complicated as this is, the easy part is the upfront part of designing and implementing. 75% of the cost is in the operations and maintenance. And I submit that it is a monstrous cost to do what we're talking about here. Thanks, Mr. Hadley.
Gentleman's time has expired. I now recognize the gentleman from Massachusetts, Mr. Moulton, for 5 minutes.
Mr. Chairman, healthcare is a human right. Everyone in America deserves good, affordable healthcare. And we all know that that is not the case today. I was having a healthcare debate with a Republican colleague not too long ago, and I asked him if he thought that the children of billionaires, say Donald Trump's children, should have better healthcare than the Marines I served with in Iraq. He considered the implications of the question for a minute and then said, yes, if they can pay for better health care, then they should have it. Well, I disagree. I don't think that the sons of billionaires should have better health care than the sons and daughters of America who risk their lives for our freedom. I think veterans deserve the best health care in the world, period. And frankly, in the greatest country this world has ever seen, all Americans deserve the best health care in the world. Now, Democrats agree on this, but we do have differences on how we get there. Perhaps the closest model for a single-payer system in America today is the VA. When I was elected to Congress, I made a commitment to go to the VA myself, to continue going there with my fellow veterans, because I said, look, until we fix this system, I'm going to go through what they're going through and see it firsthand. Well, I've seen the good, the bad, and the ugly of single-payer health care at the VA. There's some things the VA does really well. For example, the VA negotiates prescription drug prices, which Medicare does not do. And that means our prescription prices are lower and the system is very efficient. I also had surgery not too long ago at the VA. And after the surgery, I was sent home with the wrong medications. Now, they were supposed to give me a strong painkiller, and they just sent me home with a bottle of Advil, which was not what the prescription was for. But imagine if it had been the other way around, where I was supposed to get a moderate drug and instead was sent home with something much more powerful or addictive. We've all heard the stories of veterans literally dying on waiting lists. That day I checked in at the VA, first of all, they couldn't find my record, and they said they couldn't prove I was a veteran but would consider taking me as a humanitarian case. And then I sat down next to a Vietnam vet who had been sitting there for 5 hours. Personally, I think President Obama had it right, which is to have a public option. And that's what he had in Obamacare before Congress took it out, a public option that competes against existing private insurance options. I don't think the American public would be thrilled if the new president, the new Congress came in and said, you know what, we're going to just put FedEx and UPS out of business because we don't like that competition in the postal system. No, competition is good. And just like we have options for delivering packages, I think we should have options for delivering health care. Yale economist Zach Cooper found that if you stay in a hospital facing no competition, that your bill will be $1,900 higher on average than if there are 4 or more competitors. Reasonable regulation and competition among providers improves outcome for healthcare recipients, and I believe the same is true for healthcare coverage. Mr. Hadley, the report suggests that substitutive private insurance, which seems to be the closest analogy to the program I'm advocating, might also improve the quality of care for people in both private and public plans. Can you share how competition among private and public insurance plans could increase outcomes, improve outcomes, and lower costs, and share a little bit of your evidence for that?
Sure. As we discuss in the report, one of the ways in which you might have an increase in quality from having substitutive insurance is that if the substitutive insurance selected providers based on their quality, then you might see other providers, all providers, competing with each other to be selected, and through that competition, having an increase in quality overall.
Great, Mr. Hadley, thank you very much. I believe that competition is good. It's American, and it should be a hard part of our healthcare system, and I thank you for your work on this report. With that, Mr. Chairman, I yield back.
Gentleman's time has expired. I now recognize the gentleman from Texas, Mr. Flores, for 5 minutes.
Thank you, Chairman Yarmuth and Republican Leader Womack, for holding today's important hearing to discuss what the government takeover of America's healthcare system would look like for hardworking American families. The conclusions that we can draw from the Cbo report confirm what we already know, and that's that this type of upheaval abandons free market principles, severely restricts the incentive for young Americans to join the healthcare field, and then leaves the American people with no choice, longer wait times for treatment, a rationing of care, and significantly higher taxes. This flawed thought process would build the single largest bureaucracy in the history of this country to control 1/6 of our economy. Mr. Hadley, I thank you and your colleagues for being here. My first question is this: do you have a feel for what the aggregate spending would be for a single-payer system? I know you don't have a bill to look at, but what do you have? What would that be like?
We don't have an estimate yet, in part because it would depend on so many of the design choices that people
Okay.
make in terms of who's covered and what kind
Thank
of
you.
services they receive.
In the report, you say, the CBO states that the transition toward a single-payer system could be complicated, challenging, and potentially disruptive. Can you spend about 20 seconds on each of those terms, complicated, challenging, and potentially disruptive?
So it would be complicated. We talk about some of the complications in the design choices. But in the transition, particularly if you were moving so many people from one insurance plan to another, there would be an initial upheaval as you tried to reassign all of those people and get them enrolled in the new plan. In terms of disruption, depending on the payment rates and the services that are covered, there would be shifts in the economy for who would be employed, and there would be shifts in the demand for different goods and services, and so it would affect the overall economy as well.
If you look at the, we just heard some comments about the VA. It was called the good, the bad, the ugly, and one of the single largest set of issues that we have to deal with in constituent services back in the district are VA claims. And so the VA takes care of roughly 9 million Americans. It has a bureaucracy of about 378,000 federal employees to do that. So the ratio of beneficiaries to federal employees is about 1 to 24. If we were to use that same ratio to cover 372 million Americans, would that imply, that implies a federal bureaucracy of about 16 million people compared to the Department of Defense, which is the currently largest federal agency with 2 million people. What is the accurate number of bureaucrats we'd be looking to hire to take care of Americans' health care?
Again, I don't have an answer for that, in part because we don't know how the system would change from the if you look back in history, in 2017, the total healthcare spending was $3.5 trillion, all in.
I guess suffice to say it could be massive. It could be easily the single largest federal bureaucracy in the government. You could end up with many more people working for the federal government, but also having federal contractors play a significant role might also be an option for policymakers. Do you have a feel for what the improper payments are from Medicare percentage-wise? For every dollar of Medicare payments, what the improper payments are?
I don't have that number in front of me.
Okay. But we do have a significant percentage of improper payments coming out of Medicare today. Is there any reason to assume if you had a government-run healthcare system that you would have a lower percentage of improper payments on that $3.5 trillion of healthcare spending?
Well, it depends, again, on the choices in the system. One of those choices, how much they're going to invest in making sure that there are not improper payments. Some improper payments are simply because of the failure of paperwork, and other ones are the result of fraud. And depending on how much investment there is in fraud prevention, it could be higher or lower than we have today.
But you still have government running this, and so you'd have to assume that suddenly the government gets a whole lot better. It's something that has struggles with today, and you've created something massively larger, not you, I'm talking about the federal government, creating something massively larger than the VA today or than the Medicare system that we have today. The CBO report states that in a federally administered single-payer system, the associated cash flows would be federal transactions in CBO's view, and the spending and revenues for the system would appear in the federal budget. Can you explain this further?
Sure. One of the issues that we face when we are thinking about the government interacting with a sector of the economy is the extent of government control, and at what point should those be considered part of the federal budget. Under a single-payer system, it is clear that those would be governmental, and to the extent that it is administered at the federal level, then there'd be no question that all of those are federal payments. So all of the spending that would occur from such a system would show as federal spending, and then depending on the financing that's used to help pay for that, those would also show.
I want to be respectful of my colleagues' times. I'll submit all the rest of my questions supplementally, and you can answer them supplementally. But if we had a government shutdown, theoretically, all the health care payments could stop. So I yield back.
Gentleman's time has expired. I now yield 5 minutes to the gentleman from Texas, Mr. Doggett.
Thank you. A great nation should not have millions without access to quality health care. Yet we have over 30 million Americans that lack health insurance, In my home state of Texas, 1 out of every 4 working adults are uninsured. This is just unacceptable. And out-of-control healthcare costs are impacting families who have employer coverage. Over half of Americans with such coverage say that they or family members skipped or postponed needed care because of cost. More and more Americans are finding that their health insurance deductible is bigger than their bank account, and a single illness can put someone into bankruptcy. Half of patients with cancer diagnosis deplete their life savings within 2 years. Americans have so much skin in the game that they're getting third-degree burns. The system is unsustainable and unacceptable. And amidst it all, the bright spot is Medicare. Contrary to Republican attacks, the seniors on Medicare aren't languishing on waiting lists, and they're not being denied the care they need. Far from it. Medicare provides our seniors with guaranteed, cost-effective coverage that they can always count on. I know many people who would love to be on Medicare, they're just a little too young. To be sure, Medicare has some gaps. That's why I've introduced bills to expand coverage to include dental, vision, and hearing, and why I've focused on prescription price gouging. A Medicare for All system would begin by making Medicare more comprehensive for those who rely upon it today. Congressman Jayapal is the leading advocate for Medicare for All. I salute her and Congresswoman DeLauro and Schakowsky for their Medicare for America proposal, and Congressman Higgins for his Medicare buy-in proposal. Each of these has some merit. We cannot transform healthcare overnight. We'll need to phase it in, and none of these proposals is perfect, but each one has value. Since efforts to improve the Affordable Care Act have been blocked for 8 long years, we need to move expeditiously to achieve universal coverage. A single-payer Medicare for All program would be a highly effective means of accomplishing this goal. In contrast, today's naysayers don't have any plan at all. They've had 8 years to present an alternative to Obamacare, and what do we have? Republican nothing care. And their great leader, President Trump, has promised a big, beautiful health care plan that cuts costs and provides better health care for everyone. But wait, that's the same plan in almost the same words that he offered in 2016 before he began attacking protection for pre-existing conditions. And now he says he has a secret plan that must remain under wraps until after he's reelected. A translation of the attacks that these Republicans are making on Medicare for All amounts to this. Democrats want to take over your health care coverage and make it as bad as Medicare is today. Well, I know a lot of Americans who say, throw us into that Medicare briar patch. Here in the Budget Committee, we're certainly concerned about a sustainable system. There is no free lunch. The cost projected for our current health care system is $50 trillion over the next decade. We're paying that bill. It's a question of how we pay for it and how we get quality services for it. Mr. Hadley, is it true that the government is already paying for most of the health care spending in the United States?
Yes, in 2017, the private sector contributed
And
just
doesn't
over half.
the report that you've given us explain how a Medicare for All system could be financed more progressively than what we have today? With more progressive financing, isn't there a potential for many middle-class and low-income working people to actually pay less for Medicare for All than they do today for insurance through their employer?
Yes, depending on the design of the system, you could change how progressive it is.
As chairman of the House Ways and Means Committee Health Subcommittee, I've been particularly focused on the high cost of prescription drugs. I'm pleased that both the Medicare for America bill and the Medicare for All bill have both incorporated verbatim the text of my Medicare Negotiation and Competitive Licensing Act as the best strategy to deal with these pharmaceutical monopolies. This is a bill sponsored by most House Democrats. It offers a unique American solution to a unique American problem, that we're having to pay about the highest prices for prescription drugs anywhere in the world. We propose negotiation and competitive licensing to deal with these monopolies. It's essential that the Congress move forward on that this year and that it be included to deal with one of the most pressing health care problems our families face today. And I yield back.
Gentleman's time has expired. I now yield 5 minutes to the gentleman from Utah, Mr. Stewart.
Thank you, Mr. Chairman, and to the witnesses. And I'm going to go kind of quickly because there's a lot I want to cover. But before I begin, I want to say that as a Republican, I love talking about this because I think we've got some solutions that will help. But again and again and again, I hear my Democratic colleagues talk about how bad and how the system is failing Americans, which is a dramatic admission on their part, I think, because it's an admission that Obamacare failed. Because the current law of the land is Obamacare. And I think it's a fair thing to point that out. You know, and essentially what they're saying is, yeah, Obamacare isn't very good, but give us $32 trillion and another chance, and this time we'll fix it. And this time we'll fix it for real. In my last election, I talked a lot about this. It was an issue we discussed all the time, and I didn't spend much time talking about the $32 trillion price tag or the fact that you have to double taxes for virtually every American and every American business to pay for it. I think there's a more devastating aspect to Medicare for All, and that's the thing I want to focus on today. Quoting from the Cbo Report, because the public plan would provide a specified set of health care services to everyone eligible, participants would not have a choice of insurer or health benefits. Something like 60%, I think it depends on who you talk to, but it's close. 60% of Americans get their insurance from a private insurance now. They're possessive of that. They should be. They want to protect their choice and their option of providing and buying a private plan. Under the single-payer system, what do you mean when you say that, quote, participants would not have a choice of insurer or health benefits? Can you describe that quickly?
Sure, we mean that the government, whether it was federal or state, would set the benefits, and it would be one set of benefits for all participants.
One set, no choice. Is that true?
Correct, as we anticipated.
You either opt in or you opt in. Those are your choices. That's it. Yeah.
That is a choice for policymakers. They could choose to allow people to opt out or to.
Well, and I'm going to get to the opt-out in just a second. But I mean, this is the key to this, and this is what most Americans don't realize. It compels them. They have no choice. Right now, many of them think, hey, Medicare for All, that sounds wonderful. We should provide that for people. And then you say, but you will not be able to have private insurance. It's taking away your private insurance. You are compelled to go on the government program. Is that an overstatement to say that?
Well, it depends on the design of the system, but
Right, but under the Medicare for All proposal, as we understand it now.
you would have one set of benefits from the government.
Thank you. Okay, thank you. It eliminates private insurance, and I'll quote again from the CBO report. By contrast, proposals to establish single-payer systems often prohibit substantive, i.e., private insurance, because of concerns it might interfere with the operation of the public plan. Well, again, I think that's where most Americans go sideways on this. I think most of us, look, I think all of us want to provide insurance for those who don't. I don't know a single person who doesn't want to achieve that goal. But I also know that something like 60% of Americans don't want to lose their private insurance and don't want to be held outside of the law if they were to choose to do that. Now, let's suppose that they did, and this is my second point. Quoting again from the CBO report, because some nations do allow them to opt out, but here's what happens. The rich opt out and buy private insurance and leave the rest of us to suffer under the government program. Quoting CBO report, in England, private insurance gives people access to private providers, faster access to care, or coverage for complementary or alternative therapies, which the government doesn't cover, but participants must pay for it separately, in addition to paying for their individual required tax contributions to the NHS. So let me ask you this. This is a blazingly obvious question, but I want it on the record. If you provide for people to opt out, after you've raised their taxes and doubled them in order to pay for it, who's going to be able to afford to do that?
If they were required to pay those taxes and they were also then required to purchase insurance separately, then it would eliminate a lot of people from being able to purchase that kind of
Except for the elites and the wealthy. Is that true? Is that an overstatement, do you think?
I don't know about the elites, but I'll go with the wealthy.
Okay, that sounds fair. Look, under a single-payer system, using England as a model, you do have the rich opt out. That's clear. That they opt out, they buy extra insurance through a private sector, and they ultimately receive better care for that. So you have option of that, or you have the option of where I started. and that is that you compel people, and I think most Americans reject that. And my time is up. I yield back my time. Thank you for your response.
Gentleman's time has expired. I now yield 5 minutes to the gentleman from New York, Mr. Morelli.
Yes, thank you, first of all, Mr. Chairman, for organizing this very important conversation. I have the privilege of serving on the House Rules Committee, so this is the second hearing that I've been involved in that relates to changes in the, proposed changes in the Medicare system. I'm going to dispense with my opening comments, other than to say this. First of all, I appreciate very much this report. I think people on all sides of this debate, and I think we're all spending a lot of time thinking about how to get to the right place, whether it's more public investment, whether it's a private system. There are many different options. I think my colleague and friend, Mr. Doggett, I think did a good job of sort of identifying them. But the one thing your report points out, and the first part of it is it's maddening because you don't get any answers, right? We all would love to have answers here, and we'd like you to help give us the answers. But I think the thing that does point out is there are so many considerations to get here, and with many things, there could be unintended consequences if you don't think through how to get to wherever you want to go. And so this is really a very good map, and I appreciate the report. There are a lot of questions I think each of us have. I have several, in just a couple minutes, I'd like to get through a couple of them. First, it occurs to me, and you do touch on this, that if you were to design a system that was a single payer or a public system from the start, one of the choices you could make, and there would be some logic to this, is the question of not only the insurers being public, but also the providers being public. You do touch on this a little bit. I just want to ask you if you could just talk a little bit about what you see as the opportunities and challenges of working on the other end and operating essentially public hospitals and government-employed healthcare providers, which is sort of like how we have in care for our for the military. So there are some advantages to that. If you could just talk about that, because there seems to be part of the logic of this. That might be one way to approach it.
Sure, there are many different ways, as we discussed in the report, that you might compensate providers, and one of those options is to have salaried physicians, and that's an option that you see in some countries, particularly physicians who are working in hospitals. One of the questions then is about their incentives to provide care, and whether you can design that payment mechanism as a way to encourage them to both provide more services and also focus on patient health outcomes.
Are you suggesting that that might be a challenge for publicly operated as opposed to privately?
It's a choice. In both cases, it's a choice for how you structure the incentives, but it is an important consideration for both public and private.
Right.
In a fee-for-service situation that we have in many parts of our current system,
Yeah.
The incentive is to provide more care and to continue to provide more services. And there are studies that show that the incentive to do that goes beyond what is optimal.
May I stop you for a second? Because it leads into one other, the next thing that I wanted to ask you about, which is sort of the concept of global budgeting. So it does seem to me, if you have a fee-for-service system, it's hard to have a control on cost. But this is obviously, if it's going to be a public system, whether it's fully a public system or expanded public system, cost is a big issue. Your Cbo report earlier this year on the size of the deficit and the accumulated debt of the United States does raise some questions about cost containment if you expand the public system. So have you given thought, I'm not familiar, you mentioned in the report the Maryland system. I'm only vaguely familiar with it, where they've essentially gone to global budgeting. But there are risks in that. I assume at the end of the day that those risks for overruns on costs will be borne by the United States. Is there another way of doing that? Would you penalize hospitals or providers potentially?
Yes, in England, where they had a global budgeting system, they used that to constrain the growth of healthcare costs, and it was successful in doing that. But one of the consequences was that many of the providers ended up running deficits in some of those years, and then there were also increases in wait times.
I want to also just touch on briefly in just the last few seconds. You note in the report, and this is pretty well established, that the Medicare administrative costs are 1.4%. Medicare with Medicare Advantage and Part D, 6% administrative costs, and then private insurers, 12%. Are those apples to apples comparisons? And would you need to go to a public system to reduce administrative costs on the private insurance side?
So one of the reasons why we presented both numbers is they're not exactly apples to apples. It is, the 6% number is the full cost of the Medicare program, but if you are trying to use that to figure out what Medicare is compared to the private insurers, then 6% to 12 works very well. If you're trying to figure out what would happen under a different system with less investment, that it's not as useful of a number for that purpose.
Thank you. I yield back my time, Mr. Chair.
Gentleman's time has expired. I now yield 5 minutes to the gentleman from Texas, Mr. Roy.
Thank you, Mr. Chairman. I appreciate it. Mr. Hadley, I appreciate your time and that of your colleagues in being here to testify before us today. I certainly agree with my colleagues, I think on both sides of the aisle, that the American people deserve the best health care in the world. By virtue of our being Americans and by virtue of our using our ingenuity and by using our system that's before us to be able to produce that great health care. We could have that care. But unfortunately, my Democrat colleagues believe in the magic healthcare fairy and believe that where there's unlimited funding and believe that there won't be any rationing in such a system. And they then scare the American people about coverage. And they focus on coverage as being this sort of magic variable when they talk about insurance coverage or government coverage, as opposed to health care, as opposed to focusing on the one thing that matters, which is an individual in this country and their families being able to go to a doctor and get care. And that is going to happen much more effectively if we drive down the cost of care and increase the one-to-one relationship between doctors and patients, instead of focusing all of our time on government bureaucracies and, frankly, with all due respect, insurance bureaucracies, in which the system we have today is essentially single-payer health care being managed by insurance companies ineffectively and inefficiently by government strangulation by regulation. I love that my Democrat colleagues are racing to push for health care reform. I haven't met yet, especially Senate Democrat candidates for president who are now racing for Medicare for all, universal coverage, VA for all, whatever branding they want to come up with, on the back 10 years into a system created by Democrats that apparently isn't doing very well and therefore needs a new system. Mr. Hadley, let me ask you a question. Where in the Constitution is the phrase dental plan found?
It's not.
How about prescription drugs?
No.
Standard of care?
No.
Copay?
No.
Right. And so my question here is when we're talking about my colleague that was talking about states and talking about how we weren't going to allow states to be able to provide and make decisions that are best for the people in their home states, this question came up about, how we need a standard of care nationwide. And my point is just simply this: how many people are in the United States, roughly?
Roughly 329 million.
Right. How many in Texas,
I don't have that.
About 28 million. How many in California? About 40 million. And people talk about comparing systems. How many are in Singapore? It's about 6 million. How many are in Switzerland? 7 or 8 million, right? We're comparing apples and oranges around the world when we're trying to compare one healthcare system to another. And our system was designed to be a federalist system where we can have differences of opinion, where we can have healthcare systems that vary state to state. And let's take Texas. Texas is very different than Maine. My colleague, Mr. Doggett, he knows that very well, right? How many people of the current uninsured population are people who are present in the United States illegally? What estimate do you all have for that?
Could you repeat the question?
How many people of the people who are of the uninsured population in the United States are people who are present illegally in the United States?
Roughly 6 million.
Okay. And I've seen different numbers of ranging up to 30% of those who are uninsured, that number, et cetera. It is a sizable piece of the pie, and particularly in a state like, say, Texas or California, that have heavy populations of those who are present illegally. Is that true?
Yeah, as I said in the opening statement, there are roughly 11 million people who are here unlawfully, and about half of them have health insurance. The component of the in slide 3, on the backside of your handout,
Yep.
We walk through the components of who the uninsured are, and my colleague, Dr. Banton, can speak to those.
Well, without going deeply into that, just because of my limited time, I just wanted to highlight the fact that states vary. We have different populations. And I would just add that a significant portion, for example, in Texas, when we talk about the uninsured, part of the reason we have a significant uninsured population problem is that we have a significant number of illegals illegally present in the United States in Texas because this body refuses to do its job to secure the border. Let me ask a couple more quick questions in the limited time I have left. Is it true that the report states that under a single-payer system, if the number of providers was not sufficient to meet demand, patients might face increased wait times and reduced access to care?
Yes.
Would you agree with the following numbers? According to analysis done by the Fraser Institute, in wait times in Canada, a single-payer system is 8.7 weeks for a specialist after referral from a general practitioner. The analysis stated wait times of 4.3 weeks for a CT scan, 10.6 weeks for an MRI scan, 3.9 weeks for an ultrasound. Those sound right?
My colleagues are more familiar with those numbers than I am, but to characterize generally, in the United States, we have lower wait times for specialists and elective surgeries than in other countries.
When I was diagnosed with cancer, I got treatment within 10 days of the time I got cancer treatment. Thank you.
Gentleman's time has expired. I now recognize the gentleman from Nevada, Mr. Horsford, for 5 minutes.
Thank you very much, Mr. Chairman, for giving us this opportunity to discuss this very critical issue. I want to be clear. I support universal access to health care, and I am committed to working with my colleagues to achieve this goal. I commend my colleague, Congresswoman Jayapal, for her work and advocacy for her Medicare for All proposal and the many other proposals that a number of my colleagues have offered. I believe that we must work together to protect healthcare coverage for individuals who like their current healthcare plans, expand coverage for Americans who still need it, and to bring down healthcare costs for everyone. I want to just get to a number of the questions that I believe have to be answered in order for us to ever reach a single-payer system. First, though the Affordable Care Act has played a significant role in ensuring many more Americans, particularly through Medicaid expansion, the Congressional Budget Office estimates that 29 million Americans were still uninsured in 2018, 11% of U.S. residents under age 65. My home state of Nevada was one of the first states to expand Medicaid under the Affordable Care Act. In fact, my governor at the time, Governor Brian Sandoval, was the first Republican governor in the nation to expand Medicaid. Since that time, our uninsured rate declined 42.1% from 2013 to 2016. Nevada was ranked number 2 for the highest rate of uninsured before we passed that expansion. 20% of our children were uninsured before the expansion of the Affordable Care Act and Medicaid. Today, only 8%. So I reject my colleagues who say that the Affordable Care Act is not meeting its goals. More than 640,000 Nevadans rely on Medicaid, which provides health coverage to children, pregnant women, parents, seniors, and individuals with disabilities. My question, how many of these 29 million uninsured Americans who fall into the so-called coverage gap might have coverage if all states move towards Medicaid expansion?
So could we have slide 3, and then Dr. Banthen will walk through. So in 2019, we project the number of uninsured will be 30 million people.
So roughly 4 million across the country fall into the category they live below 100% of poverty, and they live in a state that did not expand Medicaid.
And why those states choose to deny their residents coverage is beyond me. Employer-sponsored health care benefits were achieved through a long and rich history of collective bargaining. Today, 49% of Nevadans receive their health care through their employer. And many of them were negotiated benefits. They gave up wage increases in order to have the health care that they have earned. Can you speak to how individuals who receive their health care through their employer would be impacted by a single-payer system?
Yes, it depends, of course, on the design of the system. If they received public coverage as a replacement for their employer-provided coverage, then we would expect that employers who spend quite a bit on that coverage would return, that's part of their employee compensation. They would return that to employees, or most of it in the form of wages or other benefits, other tax-favored benefits. But we would have to analyze the full effect of that change because employees may then, of course, face higher taxes to pay for the national health insurance, and that would depend on the design of the whole scheme.
Thank you. In your report, you note that the transition toward a single-payer system could be complicated, challenging, and potentially disruptive. Healthcare spending in the United States currently accounts for about 1/6 of the nation's GDP. Those changes could significantly affect the overall U.S. economy. What factors should we take into consideration in order to avoid a major disruption from occurring within our healthcare market?
So some of the questions about how you would get there depend critically on where you're trying to get to. And so the design of the plan, how you want it to be structured in terms of who's covered, what services they would receive are critically important, and how you're going to compensate providers. Another question then is who is it that you're most concerned about disrupting? So for example, if it is the employees who are currently employed by private health insurance companies, you could look to having a longer time period before switching over to a single-payer system, so there could be kind of more notice and warning. You could also have job retraining programs for those people. If it's for doctors and other providers, you could look at how you structure the payment rates. You could, for example, bring down payment rates kind of only to the level that has been brought down by the administrative savings that they're facing, because they're only dealing with one payer, as opposed to the current system where they're dealing with many payers.
Gentleman's time has expired, and now yield 5 minutes to the gentleman from Pennsylvania, Mr. Muser.
Thank you, Mr. Chairman. Thank you, Colonel Womack, and thank you, Mr. Hadley and the Congressional Budget Office for being with us. I speak with my constituents in my district in Pennsylvania on healthcare quite regularly. We very often discuss 3 priorities that are important to their families. Those are the ability to choose their own doctor, quality, and affordability. I'd like to focus my questions on these areas. First, regarding choice, Deputy Director Hadley, page 6 of your submitted report says, and I quote, "Participants would not have a choice of insurers or health benefits. Compared with the options available under the current system, the benefits provided by the public plan might not address the needs of some people." Close quote. Can you expand on what you meant by that?
Sure. So as I go on to say, one of the issues is about technology and how quickly a new set of insurers might adopt technology and changes in treatment patterns. And so, for example, you might expect that if there were competing private insurers, that 1 or 2 of them at least would have adopted the new technology, and that would cause the others to follow. And so you would expect in general, you might have faster adoption of new technologies than you would with one payer.
Right. So more is better and competition is good. Regarding quality, I've often heard the Canadian healthcare system described as it's terrific until you get very sick. People want to be able to go to the doctor of their choice and know that the care they are receiving is excellent. I am concerned that when the single-payer system removes choice, as we've just discussed will happen, people will not be able to choose the doctor that it best suits their particular and personal health needs. Have you analyzed how the single-payer system could and would negatively impact the quality of care that people receive?
Well, so we've thought about both doctor choice and quality of care. So let me go through doctor choice first. So it's possible that if you had a single-payer system, there might be more doctors to choose from, because essentially all of the narrow networks would be combined, and you'd only have all providers would be in one network, depending on design choices. In terms of quality design, it depends on so many of the other, in terms of the overall quality, it depends on so many of the other factors. But if there is a mismatch between the demand for care and the supply of care, then you would end up with increased wait times and problems with access to care. And to build on that just a little bit, that might mean, for example, longer, needing to travel further distances to see doctors.
So based on models that we're aware of, quality would be compromised.
Unfortunately, I can't answer that directly. It depends on the design of the system and how you are, but the extent to which you are expanding coverage and expanding the services that are covered and reducing copays, those would all tend to increase the demand for services. But if the total cost is then being controlled by reducing provider payment rates, that would tend to cause a mismatch between supply and demand.
All right, let's talk about affordability. I'm concerned about the affordability of a government-mandated and run healthcare system, both for patients and the American taxpayer. To pay for implementation of a government-run system, what would be, coming from the Congressional Budget Office, some of the ways that the revenues would be generated?
We discuss kind of three ways it could be financed through cash flows, and then there's a kind of a half. So you could have additional copays or other cost sharing by individuals. There could be premiums paid or taxes in some form or other. And then the half is you could have deficit financing that would postpone when those services would be paid for and shifted to another generation.
Right. In a system with no cost sharing, such as copays and premiums, run entirely by the federal government, the only method to generate revenue would be taxes or deficit spending. No copays, no premiums, all paid for.
If no copays and no premiums.
Right. And this system I described in my last question is what H.R. 1384 is all about, a bill co-sponsored by 108 of my Democrat colleagues, including 10 from this committee. The Medicare for All Act of 2019. The bill contains no cost sharing, thus taxes are the only way to pay for it. We know from independent studies that this will cost roughly an additional $32 trillion over the next 10 years. That's an average of $10,000 per person. For a family of 4 in my district would be paying $40,000 for such a plan, that on top of what we're paying now. That is simply not sustainable. Based upon your testimony here today, a single-payer system would result in the elimination, minimizing choice, a quality would be suspect, and $10,000 per person in new taxes. Certainly not affordable. One can conclude a government-run single-payer health system creates a monopoly that will expand the role of the federal government at the expense of patients and taxpayers. I do appreciate the CBO taking the time to join us this morning, and I urge my Democrat colleagues to work with us to develop a plan that will actually deliver on what's being asked for by the American taxpayer: choice, quality, and affordability. The government takeover of health care will make our system, and many of us, sick, $32 trillion sicker, not better. Thank you, Mr. Chairman. I yield back.
Gentleman's time has expired. I now yield 5 minutes to the gentleman from Virginia, Mr. Scott.
Thank you, Mr. Chairman. Mr. Chairman, we've been hearing a lot of complaints about the Affordable Care Act, but we did note that, as one of my colleagues pointed out, that after a decade of trying, the best the Republicans could come up with was a plan that had 20-some million fewer insured, costs go up 20% the first year, covers less, and you may well lose protections for your pre-existing conditions, and they actually passed it. Let me ask a series of questions, if I can get as many in as I can. We just heard that this Medicare for All will cost an additional $32 million. What we just heard, additional, but Ms. Hadley, I thought I heard you say that that was not in addition to, but in lieu of what we are presently spending on health care, and the total expenditures for health care may in fact go down, maybe up, but it would be in lieu of what we're presently spending, not in addition to.
First of all, I want to say that that is an estimate that was not produced by CBO, but also, yes, under the current system, looking back historically at 2017, total health expenditures were $3.5 trillion for that year.
1 year, 10 years would be 30. Go ahead.
So 10 years would be, expressed in those years' dollars, would be on the order of 35 trillion.
But that additional cost, or whatever the Medicare for All will cost, will be in lieu of, not in addition to.
Well, some of the estimates that are out there are looking at what the total healthcare spending would be, and some of them are looking at what the net cost to the government would be under that system. And then we would, if we were.
But it's in lieu of what we're spending now as a nation, not in addition to, is that right?
That's correct.
Okay, now, we've had, you mentioned less administrative expenses under a Medicare for All. Medicare, as I understand you said, was 1.4% administrative, just Medicare itself, and private sector was 12%. Is that what you said?
The federal government's cost for Medicare was 1.4%,
Okay.
but when you include Medicare Advantage and Part D,
Well,
it's 6%.
just what the government had control over was 1.4. Now, we also heard that there are a lot of improper expenditures under Medicare. And does the private sector have any improper expenses?
Yes.
Okay. You mentioned that prevention, investments in prevention there's a disincentive because of turnover. You prevent long-term expenses and they go with another insurance company. Is there also a disincentive for prevention because the private sector is worried about the quarterly earnings? And that if you had a Medicare for All, there would be more of a, again, more of a function, more of an incentive to invest in long-term prevention?
It's possible, depending on the design of the system, whether you'd give the system the authority to act on that incentive.
The public option, when the public option was considered and passed the House and lost in the Senate, there was a complaint that the public option would constitute unfair competition, which I interpreted as could provide a better product at a lower price. And the conclusion of some is we couldn't have that. The conclusion of others is that's exactly what we want to do. If that is in fact unfair competition, because it can provide a better product at a lower price, what kind of market share would a public option acquire?
That's difficult to say until we see the details of the plan, but if it is more attractive to consumers, then you'd expect more consumers to choose that plan.
And if we had that public option and people could get the benefits of the public plan, would it be necessary to eliminate private insurance?
No, you could have a public option in the context of a multi-payer system.
And you could essentially get most of the benefits of a Medicare for All, even allowing the existence of private plans so long as he didn't let them underwrite and cherry pick. Is that right?
So you would keep some of the elements of a multi-payer plan, meaning you'd still have to worry about things like selective enrollment and the competition among insurers and stability. But you could have a plan that provided benefits to more people and achieve closer to universal coverage that way.
And what would be the effect on Medicare for All on the ability to control costs?
So we haven't analyzed the specific plan that is in legislation now, but through a single-payer system, you could have additional options that are very hard to pursue today under a multi-payer system. There would be some options that we discuss in the report that would become available. Utilization management and global budgets are two of them.
But you would be better able to control costs going forward.
Potentially, depending on the design of the system.
Thank you. Gentleman's time has expired. And now recognize the gentleman from Oklahoma, Mr. Hearn, for 5 minutes.
Mr. Chairman, Ranking Member Womack, thank you for being here today. To the witnesses, Director Hadley, I really appreciate your time. I want to get right into some questions here. I've got like, 60 or so. The Democrats didn't ask for a price on this when they put it in the plan. I've read through your report, highlighted and made tons of notes. But going to the extreme of single-payer system, no private option, what's the anticipated cost? Do you argue with the $32 trillion, or could it be more? All in. Surely you've looked. You're a budget office. Surely you've looked at everything's all in, owned by the government, no private option.
But it still depends on the choices, the other design choices, such as cost sharing and critically how the providers are paid, right? So if cost sharing, or if costs were controlled through payment rates to providers, it could bring down costs sort of in two ways, both the direct effect and also if there was a shortage of providers.
So the narrative would be is that we would continue paying the providers less until we got to a point where we could afford it. Because I think you say in your report also that doctors, the reimbursement rates would go down, therefore the demand would overtake the supply, and doctors probably less likely to want to stay in a business where they're making less. And so then you also go on to state in the report that the government could step in and educate more doctors. So this is a gift that keeps on giving, where the government's more and more engaged in the process of making this work.
So yes, graduate medical education and how that's funded is one of the key issues that we highlight in the report.
And nobody's asked that question yet, by the way. Nobody's talked about how you're going to prop up the supply side.
And that's not the only way that could be done. It could also be done, there are some other methods one could pursue, for example, allowing physician's assistants and nurses to carry out services that are currently done by doctors.
So have less doctors and just keep pushing down the requirements. So we would sort of devalue the expertise we have in the medical field, people who have gone a long time to school to give us what some would argue the greatest healthcare in the world. And I know our friends across the aisle argue that, but we have people coming from these great countries like Canada and Europe coming here to have specialized treatments done because, as my colleague from Texas said, they can get it done in a timely manner as opposed to possibly dying before those procedures could be done. I've spoken to people in England who have the two-tier system, and when they have these immediate needs, because they can't afford it, they go use the private insurance and not the national health insurance.
That's right. In England, you can buy private insurance that helps have faster access to care.
And much of that's provided through these evil companies that are allowing their employees to actually buy that private health care. Is that correct?
Those are through public plan, or private plans, excuse me.
We also in there, you state that, quote, single-payer system could force compliance through an existing automatic payroll withholdings and taxes. Is that right?
That's correct.
Sounds like an individual mandate that we had in Obamacare. That when was removed, people made the choice not to actually buy insurance. Nobody kicked them off. They just decided they didn't want to buy it anymore. Is that what you could see happen as well?
So in the context of the single-payer system, what we were envisioning was that there would be taxes that would be withdrawn from the economy, not, but I see your point about an individual mandate.
So I've got so many here, but you also said that in there that about rural hospitals and about taking over the hospitals. Is it true that one of the driving forces behind negative profit margins in many of the hospitals is due to reduced Medicare reimbursement rates?
Yes, that's correct. That when the Affordable Care Act put in place a change in the way that those providers' payment rates are set, that it now includes an increase for the costs that they face and a decrease for the total level of productivity within the economy as a whole.
I really appreciate your work in this, and again, I read the report a couple times. It's safe to say that socialized medicine is and always been the Democrats' end game since go all the way back to 2000, and we can go a lot farther back than that. A one-size-fits-all healthcare comes with an unbelievable price tag that we've seen through reports, $32 trillion on the low end of cost of estimates over 10 years. Even without expanding Medicare from its current role, the Medicare Hospital Insurance Trust Fund will be insolvent in 2026. I support putting programs like Medicare and Medicaid on a fiscal sustainable path so it will be available for current and future generations. If we cannot afford Medicare as is, why are the colleagues making empty promises to the American people we could afford Medicaid for all? The problem with Medicare for all is it's the exact same problem with socialism. The system collapses on itself. And I'd ask my colleagues to be truthful to the American people and don't be, I guess, overtaken by the empty promises that big government, that this is not Medicare for all, this is Medicare for none. Mr. Chairman, I yield back. Thank you.
Gentleman's time has expired, and now I yield 5 minutes to the gentleman from California, Mr. Khanna.
Thank you, Mr. Chairman. Let me just commend your leadership for having this hearing and helping educate the committee members and the American public about Medicare for all. Mr. Hadley, do you believe Medicare for all is socialism?
We haven't drawn a conclusion about socialism. That's
Do you think anyone would pass Economics 101 if they gave that answer in any major university in this country? MIT or University of Chicago? I mean, I studied economics at University of Chicago. Do you think if someone in first-year economics wrote to a paper saying Medicare for all is socialism, that the great free market economists then would give them a passing grade?
well, Cbo doesn't have a specific, its own definition of socialism, and socialism.
Just given the economic definition, which is that you control the means of production, I mean, do you think that this is socialism under common economic definitions?
Well, so it would involve more government control over one aspect of the economy.
So you can't say that it's not socialism?
No, we can't speak on it either way.
Okay. I mean, I think 99% of the people with PhD economists in this country would say it's not socialism. As you know, the employer average premium is $12,951 of cost to an employer under the current healthcare system. Most economic studies show that the stagnation of our wages for the last 40 years are directly tied to increasing health premium costs. Can you speak to how much increase there would be on wages if employers weren't being burdened by the $12,951?
Well, as my colleague can explain further, you'd expect a significant portion of that to be passed back to the employees.
Yes, we would expect employers to pass back most of that in the form of other compensation or wages. However, employees would then face taxes related to the national health insurance.
Do you think that one of the biggest things our country can do to deal with wage stagnation of the bottom 50% of income earners is to reduce the burden that employers have in premiums?
So the bottom 50% of earners do not always receive health insurance through their jobs.
Bottom 50% who have health insurance through their jobs. Do you think one of the biggest things we could do in terms of wage stagnation is to reduce employer costs on healthcare?
I don't know what it would happen to growth in wages over time. It would certainly cause a change in during the transition from private to public health care.
It would be a massive raise for most Americans.
We would expect to see an increase in wages, but if the scheme were financed through payroll tax, they may not take all of that home in their paycheck.
Sure, but even if it was financed through a payroll tax, it would be a net increase for most Americans, correct?
I'm sorry, that would depend on the details of the tax system, sir.
I mean, there's no way that a tax would be $13,000 on any economic study. You've testified earlier to Mr. Doggett's questions that most Americans would actually, who are making under $75,000, would save money by having less costs of premiums than they would have to pay in the payroll tax. Isn't that correct?
So I think what I said was that you could design a system that would be more progressive than the current system if you were considering what they're currently paying for healthcare as a tax. So, but that's really a choice that policymakers have in front of them, not a conclusion that we can draw about the choices that you've already made.
But you could design a system, in your view, that the ordinary American who's watching this would pay less money in terms of the fee to the government than they currently are paying to healthcare, and they would get more money in their pockets in terms of increased wages. I mean, it's possible to design that system.
It's possible to design a system that would do that for some people, yes.
And most economists would not describe that as socialism. I mean, unless you believe that reducing people's costs and increasing their wages is socialism. You get the last word.
No, they would not describe that as socialism.
Thank you.
Thank you. The gentleman's time has expired. Now yield 5 minutes to the gentleman from South Carolina, Mr. Norman.
Thank you, Mr. Chairman. Mr. Hadley, thank you, and your colleagues for coming. You know, the way to predict the future is look to the past. And, you know, I think we all remember during the Obama years, during Obamacare, the statement You can keep your own physician. How'd that work out? Not too well. I think we remember the statement, we're going to have reductions in our deductibles. How did that work out? Not too well. In my state of South Carolina, we've got that single mom who's supporting 2 or 3 children. Her premium skyrocketed 62%, not 15 to 12%, as I've heard. How did it work out when they promised lower deductibles? Not too good. Let's look to the other countries that have, you can call it not socialism, but government-run systems in anything is pretty much socialism if you really look at it and get down to the bottom line. Let's look at the Great Britain. Look at the shortages in physicians. 11,500 physicians short. 42,000 nurses short. Let's look at Canada. As Mr. Roy said, he had his treatment for cancer in 10 weeks. How does this Canadian system work out? Well, it took patients 8.7 weeks to see a specialist, 4.3 weeks to get a CT scan, 10.6 weeks to get an MRI scan, and 3.9 weeks to get an ultrasound. My son-in-law from Canada, when they had heart trouble, guess where he came? Not Canada. He came to the United States of America. So, you know, the old system is not sustainable under Obamacare, so I welcome this discussion to get into how we're going to improve it. It's not government-run health care. Mr. Hearn and I are in the private sector. He has restaurants. I'm in the construction world. You think government can do it cheaper than we can? No. Competition is what makes us a better product at cheaper prices. I keep hearing this word free. Okay, I'm for free medical care with the caveat, get the doctors to work for free. I'm for free education. Get the professors who are tenured to work for free. Get us as Congress to work for free. So this is what we're talking about, and I'm glad to have this discussion. Incentives. Why has there been any study on the incentives? Would you get more people in the medical profession if you cut their pay? Have you done any type work on that, Mr. Hadley?
I haven't, but my colleagues have looked at that issue, and they've seen that in the context of a multi-payer system, I need to come back to that in a second, that if you cut the compensation of providers, they provide less care. But the caveat is that was in the context of a relatively small change to within the context of a multi-payer system. They had other places to go. It's hard to know exactly how that would play out in the context of moving to a single-payer system.
But you would agree, if you cut the incentives, you're not going to have the physicians getting into the field to practice their skill if you cut their pay. Does that make sense?
In general, we would expect that fewer people would enter the medical profession, and whether that would result in a shortage of services would depend on the incentives faced by the people who remain, and also the extent to which we have foreign-trained doctors.
Do you agree if it's a shortage of physicians, that would mean less doctors to see patients that need care, so the patient will ultimately suffer?
It could result in reduced levels of care, in part because of wait times.
Okay. And finally, our nation's debt is now $22 trillion. It's been estimated that the single-payer system would add $32 trillion. Bottom line, you can say that it adds to it. It's net. But bottom line, you're looking at a big number, and you're looking at a number that is unsustainable as we look forward to, as we try to get a system and get this country back on a firm financial footing and not finance it with a credit card. Would you agree?
So 2 things. One, it would be a very large shift to move all of the private payments that are currently financing the healthcare system to become public payments, and that would require substantial additional government resources. But more generally, the current level of debt and deficits are ultimately not sustainable.
Not sustainable, not going to be for the United States as it hasn't been for any of the socialistic countries who are basically going broke. I would say that anybody that believes that a government-run healthcare system provides better health care at lower prices, I got some land that's underwater I need to sell you for high-rise condos. Thank you so much.
Gentleman's time has expired. I now yield 5 minutes to the gentlelady from Illinois, Ms. Chakowski.
All this talk about socialism, That's exactly what we heard when Medicare was suggested. In fact, Ronald Reagan was the lobbyist who went around the country against Medicare because it was socialism. I don't know about the VA. That sounds like a socialist system to me, too. That is a single-payer system provided for our veterans. Social Security, oh my, that is definitely socialism, according to my Republican colleagues. And a single-payer system would not be any more socialism than any of those current government-run programs that people like. And in fact, the idea of Medicare for All is really popular out there. It polls really well. Be careful of your slams against socialism. People want to have health care. The United States of America currently pays more for health care than any other country. Is that right, Mr. Hadley?
Yes, that's correct, both on a per capita basis and as a percent of GDP.
Thank you. And isn't it also true that in terms of outcomes, we are lower than most of the industrial countries in the world? Is that also true? Longevity. Let's talk about maternal mortality. Is that true?
So for longevity, yes, among the OECD countries, the United States is below.
We're the only industrialized country where actually our maternal mortality has gone up instead of down. Is that not true? It is true.
Correct.
So we need a bold plan here. And I am on every bill to improve health care. I've been for Medicare for All since many of you have been born. But I'm also the co-sponsor of Medicare for America. I helped write the Affordable Care Act. I'm for improving it. I'm for all the plans because what we have now is not working. My colleagues talk about wait lists, but your report, Mr. Hadley, showed that 29 million Americans are uninsured right now. They're not even in line. So there are people who never are going to get the kind of care that they need right now if they can't pay out of pocket. Isn't that true?
That's correct, although they do seek care through other sources, charity care, and so there can be some uncompensated care. But more generally, there are also people who have insurance that forego medical care because they can't afford the out-of-pocket.
A lot of people. So people are waiting 5 weeks, 5 months, or whatever you said about Canada. How about your entire life waiting? Because we see people die. And in fact, before the Affordable Care Act came in and Medicaid expansion came in, people were actually dying. And when we opened it up, we saw people who had stage 4 cancer because they had avoided going to the doctor. There was a really bad editorial yesterday, I thought, by Mr. Scalise, talking about how bad a Medicare for All system would be. What effect would that have if we had Medicare for All on women's health care and the full range of reproductive services? Someone answer that?
So it depends critically on the design of the system and the services you choose to cover. So in the context of a single payer system, we lay out those as design choices, but we haven't analyzed any of the specific proposals.
Okay. Did you want to say anything?
Yes, well, the uninsured women would then get access to coverage and benefits, so that would be an improvement.
I mean, we have, before the Affordable Care Act, being a woman was a pre-existing condition. I also just wanted to say to my colleagues, the idea of choice. You know what? Americans don't love picking an insurance company. They don't love insurance companies. Americans want a full comprehensive package of benefits. You say they want to choose benefits? No, they want to know that those benefits are there. What Americans want is a choice of doctor. And what I heard you say, Mr. Hadley, was that if there were Medicare for All, there actually might be more choices of providers. Is that right?
That's correct. As you can imagine, that all of the different networks that exist today would be sort of combined so that all of the providers would participate and be potentially available.
I yield back.
Gentlelady's time has expired. I now recognize the gentleman from South Carolina, Mr. Timmons, for 5 minutes.
Thank you, Mr. Chairman. I'm going to begin by talking about Blockbuster. I went to Blockbuster all the time as a kid. I loved it. I got 2 or 3 movies. My parents were happy. I shut up and I was downstairs watching television. Blockbuster doesn't exist anymore because Netflix, Apple, Amazon have driven them out of business. They provide a better service, higher quality service, cheaper price. That's the free market. That's capitalism. That is what, in many respects, the American system of enterprise stands for. So what we're talking about today is literally going to evaporate trillions of dollars of wealth. I'm going to start with insurance companies. So the largest insurance company in the country is United Healthcare. They have 300,000 employees. Last year, they had $226 billion in revenue. Shockingly, it's actually headquartered in a member on this committee's district. It's headquartered in Minnesota, and that member is actually a co-sponsor on this legislation. What would single payer do to United Healthcare, to their employees, to their revenue? So I guess I'm just going to start, Deputy Director Hadley, is it safe to say that a transition to single payer healthcare would be extremely disruptive to the hundreds of health insurance companies in this country?
Yes, I mean, depending on the role that was left to them by the system, and most of the single-payer systems that we've looked at in the world have a very limited role for private health insurance. And if there's a much more limited role, then you would expect a substantial reduction in share value and employment within the health insurance industry. But by that same token, there would be the need to have more people administer the single-payer plan. And so some of the people who currently administer the health insurance plans could be employed by the government or its contractors as it administers the plan.
I guess if we're going to legislate them out of work, they probably will be looking for a job, might be able to find them one in the new system, but it would still evaporate hundreds of billions of dollars of investment from the private sector. So I'm going to go next to medical device sales. Fresenius is a German-headquartered company, but 70% of the revenue came from North America. That was $20.7 billion. They have 270,000 employees worldwide, but again, 70% of the revenues in North Carolina. North America, you got to assume that many of them are, I didn't do that, are here in the United States. So the next question, Mr. Hadley, is it safe to say that the transition to single payer would be extremely disruptive to the medical device sales industry?
Yeah, I mean, we would expect there would be substantial changes to all of the participants in the healthcare system. How the providers of medical devices were compensated would determine how affected they were, and that's a design choice for policymakers.
So again, billions of dollars legislated out of existence, billions of dollars of private investment legislated out of existence, and tens of thousands of employees free to pursue new opportunities. That doesn't seem American to me. We don't nationalize things here. That's what socialist countries do, and we've seen how that's gone. I'm going to go last to clinicians. So I spoke to the CFO of the largest healthcare provider in South Carolina this morning, and she told me that it was just virtually impossible that clinicians would not see a reduction in their compensation if we went to single payer. Not to mention the fact that we would be conscripting them into federal service and likely result in fewer people being interested in becoming a doctor or a nurse. That doesn't seem to be a good outcome for the healthcare system in this country. So I guess we've been talking about what's wrong with this proposal, and we don't really have a very good alternative. So the question is, what do we do? And I would say that the answer lies in aligning the interests of the interested party. So you have the individual who needs to have personal responsibility and make sure that they are as healthy as possible, diet and exercise. Then you have the government, you have pharmaceutical companies, you have medical device sales, insurance, hospitals or healthcare providers, and clinicians. So these are the 7 interested parties, and we have to align their interests to reduce costs, maximize the output, and make our society healthier. We can do it at a lesser cost, but we have to work together. And it seems that all we're doing is talking about Medicare for all, and some people think it's great, some people think it's terrible, but it's not a solution. It's not an American solution. It's not a viable solution. It will never pass Congress. So we need to work together to find a real solution. And I look forward to working with everyone willing to align the interests of all the different parties and find a way to make our society as healthy as possible. So thank you, Mr. Chairman. I yield back.
The gentleman's time has expired. I now yield 5 minutes to the gentlelady from Washington, Ms. Jayapal.
Thank you so much, Mr. Chairman, for driving this conversation forward on single-payer health care, and to the CBO for producing what I think is a very helpful document and guidance towards what that system should look like. As Chairman Yarmouth said in his statement, it's not a question of if, it's a question of when our country has single-payer health care. And I, along with 109 co-sponsors now, we just added one, and we will continue to add a couple more over the next several weeks, have introduced a single-payer proposal called the Medicare for All Act of 2019. It had its first historic congressional hearing ever in the House of Representatives and the Rules Committee. We look forward to doing that here. I understand I have bipartisan support for that hearing, because I actually think that this is exactly the kind of proposal that does address many of the things that have been laid out in the CBO report. So, Mr. Hadley, according to the CBO report, how much did we spend on healthcare in 2017?
$3.5 trillion.
$3.5 trillion. And how does that $3.5 trillion, and that's annually, correct?
That was
So that's
17. That was the amount.
That's
spent in
2017. So over 10 years, if we continue to spend $3.5 trillion, it would be $35 trillion. We're going to talk about that in a second. How does that $3.5 trillion, which takes up 18% of our GDP, compare to other peer developed countries?
It's significantly higher.
Significantly higher than what other countries are paying for their health systems. So our current system costs $3.5 trillion. It is actually projected to cost $6 trillion by 2027, the most in the entire world by far. And yet, we have 29 million people without insurance, which you pointed out in your report, and another 44 million who are underinsured. Almost 1/4 of our country, the richest country in the world, is unable to access health care. Is a single-payer system capable of providing coverage for everyone and achieving universal health care?
Yes, a single-payer system could achieve universal health care.
That is a yes. I like your answers so much, I'm going to repeat them. A single-payer system can achieve universal health care. Great. So, unlike our current system, if we move to a Medicare for All system or a single-payer system, depending on its design, of course, we could achieve health care for everyone. Let's talk about what it can do for costs. The CBO report provides a great list of design choices for single-payer that could bring savings for our system, such as administrative costs. In your testimony, you described the potential for considerable administrative savings because single-payer insurance, like Medicare, has significantly smaller administrative costs than for-profit insurance. Our doctors and hospitals also have administrative costs of 25 to 30%, while hospitals in the single-payer countries spend less than half of that. This is a huge drain of time and resources spent dealing with for-profit insurance and billing at the expense of the health of patients. And another great benefit of a single-payer system is that when you bring everyone into one system, you gain significant market leverage. So compared to a for-profit insurance company, would a single-payer system have more leverage to negotiate better prices for hospital costs?
Yes, because under the current system, insurance companies' market power is fractured. If that were combined in a single-payer system, there would be more leverage, and it would depend on the design of the system to see how the government would act on that leverage.
But we could use the tremendous leverage of government power and a large marketplace, essentially, a large system of consumers, to negotiate the best prices for the American people, which I think is exactly what people want us to do. And a single-payer system like Medicare for All would also bring us universal health care coverage as well as market power to generate even more savings from hospital costs. And we can use the same principle to reduce drug prices so that we're not paying twice what other countries are paying as we do now. So there is a clear economic case for Medicare for All, and I wanted to read from a letter that came from over 200 economists yesterday. This is Economists in Support of a Medicare for All healthcare system, an open letter to the Congress and people of the United States. And I'll just read, Mr. Chairman, from the first paragraph. As economists, we understand that a single-payer Medicare for All health insurance system for the United States can finance good quality care for all U.S. residents as a basic right, while significantly reducing overall healthcare spending relative to the current exorbitant and wasteful system. Healthcare is not a service that follows standard market rules. It should therefore be provided as a public good. And evidence from around the world demonstrates that publicly financed healthcare systems result in improved healthcare outcomes, lower costs, and greater equity. I ask unanimous consent to introduce this into the record.
Without objection?
Thank you, Mr. Chairman. I'll just end by saying, here's what, people who are tuning in, here's what you get from a Medicare for All universal healthcare system. First of all, you get comprehensive benefits like medical, dental, vision, mental health, prescription drugs, long-term care. All of this with no copays, private insurance premiums, or deductibles, and you get more choice than you have now because there's no out-of-network hospital or doctor. Everyone is in network, and the same hospitals and doctors you see. You never have to cut pills again or be the 1 in 5 who skip prescriptions because Medicare for All would actually negotiate those drug prices down. So, Mr. Chairman, I can't wait to have the hearing on my bill. I can't wait to take on the Republican colleagues across the aisle who think that this is somehow a bad thing. The American people want this, and I am ready to work to deliver it. Thank you so much.
Gentlelady's time has expired. I now recognize the gentleman from Tennessee, Mr. Burchett.
Thank you, Mr. Chairman, ranking member, and members of this panel. I would, knowing coming in here, I would probably rather take a beating than come in here, and I've taken a beating. You can ask some of my colleagues on my side of the aisle, and I appreciate you all. Your all's willingness to be here. And Mr. Hadley, these are some questions I have for you. I know that you previously served as general counsel for the CBO. That's correct?
That's correct, for 8 years.
Yes, sir. Okay. The CBO report states, by owning and operating hospitals and employing physicians, the government would have more control over the healthcare delivery system, but also take on more responsibilities. As I'm sure you're aware of, the takings clause under the Fifth Amendment, I believe it's the last clause in the Fifth Amendment. Has the CBO mentioned or referenced those issues from a budget perspective in past records, scores, or studies?
So Fifth Amendment takings issues have arisen in previous cost estimates. And when we have looked at them, it's typically been in the context where a government action was going to be clearly taking private property, and we estimated the cost that the government would pay. So within the Treasury, there is what's called the Judgment Fund. It's a permanent indefinite appropriation to pay claims against the United States. And one of the types of claims that that fund can pay are constitutional violations like a Fifth Amendment taking. And so we have, on occasion, estimated the cost of the federal government of paying that compensation.
Okay. Would you be able to show the those in a cost estimate of one of the specific proposals that are out there?
We'd be happy to send you one of those cost estimates.
Great. And what design considerations do you weigh relating to the federal government taking property and compensating private sector entities?
Well, so if we were talking about a physical taking of property where they were actually taking over the property themselves, then the analysis is mostly on the side of trying to figure out how to value that property and what its value before the taking was. If it's as you know, if it's a regulatory taking, then it's a more complex analysis.
Right. Of course, they'd be taking a hospital, there'd be physical property, and I assume there would be some formula for that.
We would try to figure out what the compensation was owed for the value of that asset.
Okay. How would you approach those issues if the government were to take these hospitals and just for public use? Would there be a separate way of doing that, or would there be something out there that you could rely on?
Well, in both cases, we would be looking at the degree to which government control was being exercised. So when we think about the boundaries of the budget and what's included within the federal budget, we look to the degree of federal control as one of the primary factors for when all of the activities of an entity are included within the budget. So there are a few instances where there are private entities that are so thoroughly controlled by the federal government that all of their cash flows are considered to be federal cash flows.
And what would you think of if they were to take one of these hospitals or private companies without compensation for the takings?
Well, we'd look at the specifics of the legislation and of the action, and it may be difficult for us to gauge exactly what a current administration or future administration would do with the authority that they're given. But with those caveats aside, we would look to see what the legislation would do and how much it would cost. And one of the components of the cost that we would consider would be claims against the government.
Okay. Thank you, Mr. Chairman. I yield back the remainder of my time.
Gentleman yields back. I now yield 5 minutes to the gentleman from California, Mr. Panetta.
Thank you, Mr. Chairman. I appreciate this opportunity, and let me take this time to thank the witnesses for being here as well as their preparation in order to be here. Thank you very much. I apologize for coming in late. I had another hearing, so bear with me if I've asked questions that you've already heard. Obviously, I'd like to not only thank the witnesses, but again, thank the chairman for holding what many here in this room and many here across this country consider a very important hearing. Obviously, it's important to the families in my district on the Central Coast of California who are very worried about their health care. And we all understand that the Affordable Care Act was clearly an important step in the right direction. We also know that there's a lot more work to do. Unlike 97% of California's residents, many of my constituents are unable to shop around on the individual market in order to choose the best insurance for themselves and their families. In 2 out of the 4 counties in my district, Monterey and San Benito counties, there's only one insurer on the exchange marketplace. As you know well, that lack of choice sharply increases premiums, puts many of my constituents in high deductible plans, and it creates a lot of high out-of-pocket expenses. To make matters worse, Congress reduced the individual mandate penalty to 0, and the Trump administration proposed policy changes that would promote insurance plans that do not meet CBO's definition of health insurance. These actions have left many of my constituents without health insurance and actually provided limited options for many of them who want to seek insurance on the marketplace. Can any of you explain what role the Trump administration's expansion of short-term limited duration STLDs, as we know them, those types of plans and association health plans, what they have played on expanding coverage in the individual market, in that sense that have these actions increased access to quality health insurance, or have they helped people with pre-existing conditions? You can talk about that.
So we believe that short-term limited duration plans will become more common starting this year because of the change in regulations. Some of those plans will not provide coverage that meets what we consider to be coverage. Our definition includes a plan that provides some comprehensive major medical benefits, that is, would cover a serious illness. So some of these plans have limitations on what they pay, and so we don't consider them coverage. However, we do think some of them will continue to provide major medical benefits, often with very high deductibles, even higher than those in the marketplace. They are underwritten to these. They will sell them to everybody, but if they decide you've used that coverage for a pre-existing condition, they may not pay that bill retroactively. Right now, those plans are small in number. We estimate fewer than 2 million.
Understood. Great. Now, in my area, there's obviously a good amount of rural area, and so we have a lot of rural hospitals as well. I was wondering if you could address what a single-payer system would do to help reduce costs for these types of hospitals in those rural areas.
So, many rural hospitals, I don't know about your district, are in, they're called critical access hospitals, and they receive higher payments than would be otherwise provided under Medicare because they're recognized as critical access. They often treat a lot of public pay patients as well as patients who are uninsured it is possible, under a single payer, that some of those rural hospitals would actually be better off and get more payment for their patients than they do today, because some of them are uninsured.
Or do, other countries that have single-payer system, how have they dealt with the rural hospitals, and how has that contributed to the rural hospitals? If you know, sorry to put you on the spot.
I'm sorry, I don't know about rural hospitals in other countries.
Okay.
We can look that up and get back.
Okay, I'd appreciate that. Anybody else?
No.
Okay, thank you. Mr. Chairman, I yield back.
Gentleman yields back. I now yield 5 minutes to the gentleman from Texas, Mr. Crenshaw.
Thank you, Mr. Chairman. Thank you for this opportunity. I think it is time to put the rest, the many false promises of Medicare for All and single-payer systems. Mr. Hadley, I want to start with talking about supply. On page 22 of the report from the CBO, you say, studies have found that increases in provider payments rates lead to a greater supply of medical care, whereas decreases in payment rates lead to a lower supply. Is this correct?
That's correct. That's what the report says.
So price controls, which are necessary when moving everyone under one payment rate, it affects supply, correct?
Yes, it can.
A single-payer system using current Medicare reimbursement rates decreases the number of doctors. They simply don't get paid enough to keep up with expenses. Second point, triage. Under single-payer systems, do providers typically bill for whatever they want, or is there an approved treatment list?
Typically, there would be an approved treatment list.
Thank you. Generally, in single-payer systems, is the government or a government body in charge of listing out national guidelines and standards for practice that doctors must follow?
So usually it's a set of standardized practices, but that can be done sometimes by an independent advisory board and sometimes...
Somebody has to do it. Under these systems, what are common methodologies for deciding what is listed on the national guidelines or standards? Is it a cost-benefit analysis?
Yes, they look at cost effectiveness, but then for the prices for those, sometimes it's through negotiation.
So what we get to, maybe it's a government bureaucrat, maybe it's a third party, but a bureaucrat is using a cost-benefit analysis formula that will decide what a patient is approved for. Third thing I want to hit, innovation. So we have two issues here so far. We have lower payments to providers and a government-run list of approved care options. So we have to ask ourselves, why would anyone invest in new cutting-edge medical technology or medications? You won't get paid as much. You're not even sure the government will allow doctors to use your new innovation. How do you think that changes the calculus of investors? It changes it enormously. Fourth thing I want to hit, quality of care. In your report, you write, if the number of providers was not sufficient to meet demand, patients might face increased wait times and reduced access to care. Is this correct?
That's correct.
And later in your report, you say public plans might not be as quick to meet patients' needs, such as covering new treatments. Correct?
Correct.
If we measure quality of care and wait times and innovative new care, wouldn't we agree that quality is decreasing? So there's less providers, there's less innovation, longer wait times, and overall less quality. This isn't even the worst part. Let's move on to who this might actually hurt the most. Director Hadley, in your testimony, you write, the public plan would provide the same set of healthcare services to everyone eligible, so it might not address the needs of some people. For example, the public plan might not be as quick to cover new treatments and technologies as would a system with competing private insurers. In your testimony, you're saying that a single-payer system might not address the needs of some people who need access to new treatments and technologies, correct?
That's correct, depending on the design of the program.
And would you say that some of these people who need new treatments, they could be patients with cancer, genetic disorders, patients who suffer from 2 diseases like fatty liver disease or diabetes, all of whom have very complicated, complex conditions?
It would really depend on how quickly and which technology or treatment was being provided and which group that affected.
Sure, but in your testimony, you said some people, and it could easily include these people. Could those people that I just listed also be described as people with pre-existing conditions?
Yes.
So, a single-payer system is worse for people with pre-existing conditions. A private system is better for people with pre-existing conditions than a public system. Let's talk about what we've learned here. Let's summarize it. A single-payer system has to set prices, and if set at current Medicare rates, which all plans call for, then this drastically cuts the money going to doctors and hospitals. They will have to cut resources. They will hire less. They will buy less equipment. It is simple economics. Because there are less doctors, wait times will increase. With this newfound world of less doctors and more patients, the government will have to carefully screen or triage who gets care and who doesn't, and what kind of care they get, all based on bureaucratic cost-benefit analysis. Innovators will be less likely to invest in a system where the payoff is significantly less because they can't be sure whether the government bureaucrat will even allow doctors to use that new medical device, medication, or new procedure. And counterintuitively, this system ends up hurting patients with the most unique conditions, also known as patients with pre-existing conditions, because their care requires flexibility and innovation, both of which are drastically reduced in a single-payer system. Thank you, Mr. Chairman.
Gentleman's time has expired, and I yield 5 minutes to the gentleman from Missouri, Mr. Smith.
Thank you, Mr. Chairman. Welcome to the Democrat House Budget Committee. We are 37 days past the statutory deadline for a budget. And CBO is here today to discuss an analysis of a bill that would overhaul our healthcare system so dramatically that they can't even estimate how much it would cost. Without a budget and without talking in real numbers about how much this bill would cost the American public, we are wasting our time today. But since you want to talk about single-payer healthcare systems, let's look at the results of government-run healthcare. Canada is celebrated by my liberal friends as a prime example. If a Canadian sees their primary care doctor for a checkup and their doctor recommends that they go see a specialist for a closer look, it could take nearly 20 weeks. 20 weeks. If a patient has knee problems and is struggling to walk after their first doctor's visit, it will take 39 weeks to have their knee surgery. If their knee problem gets worse while they're waiting, they might not be able to walk. That's when people miss work, when they miss their wages, and they can't attend family events like their kids' sporting events. How about cancer? The median time for a patient with cancer to start treatment is nearly a month. Nearly a month. Imagine being diagnosed with cancer, having to wait 4 full weeks before getting treated in Canada. In England's single-payer health program, the British National Health Service canceled 50,000 non-emergency operations like cataract surgery and hip and knee surgeries, including replacements. Bottom line, single payer would impose long wait times and delays even for basic procedures and emergency medicine. What about cost? CBO hasn't even attempted a cost estimate. Medicare for all, by other projections, will cost $32 trillion over 10 years. That would cost every household in America $25,000 a year. Every household in America, $25,000 a year. Our seniors who currently rely on Medicare would have their care disrupted too. After a lifetime of work to earn their Medicare benefits, America's seniors would be forced into a one-size-fits-all government-run healthcare system no longer tailored to the needs of our older citizens, but one that rations care and limits their access. CBO says it themselves, quote, patients might face longer wait times or a decrease in quality, close quotes, and could, quote, worsen if provider payment rates were simultaneously lowered or more stringent cost containment methods were implemented, close quotes. You thought IPAB was bad. We're talking about the real-life death panels right here. This is what Medicare for All gets you. Americans would have no choice but to pay more, to wait longer for lower quality care. Let's talk about access to care for rural Americans. Mr. Hadley, an alternative scenario published earlier this year by the Medicare trustees showed that looming physician cuts and cuts to hospitals due to Obamacare's productivity cuts would put most providers out of business. My question is, what happens in this scenario when we assume all providers get Medicare rates?
That's a complicated question for thinking about what it means for rural providers. So in general, you'd expect that the total amount of compensation going to hospitals would go down because right now commercial rates are on average higher than Medicare rates. So if you went to the lower level, compensation would go down and so margins would go down. But there's an important caveat for all hospitals, which is what is the degree of uncompensated care that they are currently providing. And if that became compensated care, then that would make up some of that difference. In addition, in the context of rural hospitals, a greater proportion of them have lower margins than urban hospitals, and a greater proportion of them are running negative margins than urban hospitals. But that's in part because they already serve a greater share of patients with public insurance plans. And because of that, they're already both receiving less, they'd be somewhat less effective, but they also have less margin to work with.
Gentleman's time has expired. And now yield 5 minutes to the gentleman from Georgia, Mr. Woodall.
Thank you, Mr. Chairman. I'm a little embarrassed. I hadn't thought about what Mr. Smith said, that we're here talking about doubling the size of the federal budget, and here on the Budget Committee, we haven't passed a budget yet. I know it's tough to find 218 votes on one side of the aisle or the other, but I've said it before and I'll say it again. You're the right leader. Colonel Womack is the right leader to bring a bipartisan group together around a budget. Just seems silly that we're going to take over 1/6 of the American economy, and that takeover is going to be conducted by a government that can't even figure out how to pay its own bills year to year. But we can do it, we just haven't done it. Let me start, Mr. Hadley, I had the pleasure of being on the first Medicare for All hearing on the Rules Committee, and we learned there that Medicare for All abolishes all of the Medicare Advantage programs, which about half the seniors in my district take advantage of, so that Medicare for All means something for all, but you're going to lose access to Medicare Advantage. What you say in your report, if I'm reading it correctly, is thinking about utilization management as one of the cost containment procedures. You say it would impose new constraints on the choice of health care services for those who were previously enrolled in the Medicare fee-for-service program. Is that correct?
That's correct. You could have, using utilization management as a technique to control costs is an option for policymakers, and there are a variety of different strategies you could pursue, and we detail those in the report.
But our current Medicare beneficiaries, those who've been paying in through their entire life, payroll tax, largest tax that 85% of American families pay, folks today are not burdened by that constraint. Is that correct?
Correct. In general, most of Medicare is fee-for-service or voluntarily.
They've either opted into a plan that's going to go away even though they chose it, or they've stayed in general Medicare, which is also going to go away because they're not subject to those utilization procedures. You said something in response to a question earlier about improper payments. You said it would, the question was whether or not improper payments would be higher under a Medicare for All system. And you said it would depend, improper payments could be higher or lower than today, depending on the investment in fraud prevention. You all look at our numbers every year. Is it CBO's position that we have not yet reached the maximum utility of fraud prevention efforts in the Medicare system, that if we hired more fraud preventers, we would get more than a dollar-for-dollar return on that in today's system?
Yes, that's correct.
About how much elasticity is there? Where are we 10% short in fraud preventers? Are we 20% short? It just seems like among the things that we could all agree on, nobody wants to see improper payments go out the door. It's wasted resources. How short are we, Dr. King?
I don't have the exact numbers, but we're not that close to the threshold.
I would appreciate that if you could. You don't have to reinvent the wheel for me, but if you could point me in the direction after the hearing, I would love to try to build some bipartisan consensus on fixing that issue. I think that we could. The report says a single-payer system that collected comprehensive data on patients' use of healthcare services could potentially manage available resources more efficiently. That certainly makes sense. I don't think that was a radical conclusion. But what was surprising is you went on to say in the United States, public programs, those single-payer systems that we have today, have implemented few utilization management programs. Why do you think that is, that you have identified an area where we could do better, and yet in the programs where we have an opportunity to do better, run by at the federal level, we're not doing that?
Well, so one of the reasons is, in general, we are still operating under fee-for-service in many areas, but also in order to have that degree of coordination, you need more providers talking with each other, and that means, one way to get there would be having a IT system with medical records that are completely interoperable. But that's not the only way. You could do it in some other ways. But I think the two main reasons are that so far we have chosen to do things as a fee-for-service, or we've struggled with our own systems.
Well, I'd point that out, Mr. Chairman. I think Mr. Hadley is right in our programs like Medicare, like Medicaid, that are single-payer systems. For whatever reason, the political folks who craft those programs, the policymakers, have chosen to keep them as fee-for-service systems, to not implement aggressive utilization management. We would have to implement aggressive utilization management to bring down costs in a Medicare for all single-payer system. I'd like to explore why it is that we've not done that in places that we could do that today to bring down costs. And if it's because the American people are adverse to it, perhaps we should learn that lesson first with a smaller pool before we expand it to a larger pool. I'm not sure you all changed anybody's mind today, but I believe that CBO makes it a point not to try to change anybody's mind and just provide good data. So thank you very much for doing that.
Exactly. That was not their role to try to change people's minds. Thank the gentleman. And now I yield 10 minutes to the ranking member, Mr. Womack.
Thank you, Mr. Chairman. And again, I appreciate the opportunity to have this conversation today, and perhaps there will be more to come on these types of programs. I want to go to my last thought first, and that is Director Hadley, or Deputy Director Hadley, let's assume for the sake of the argument that the United States of America did move to a Medicare for all type structure, universal health care. Is that something that can be done as an experiment with the population at large, 329 million people? Or if we went to that program and it didn't work, what then? So in that scenario, what would happen? In other words, we either have to be all in or not all in. Is that correct?
So you could have an extended period of transition, but if you go all in, and then that results in insurance companies dropping in value and the disruptions to workers that all of that we detail in the report. If that occurs, then how we would respond is very difficult to understand. And I think this is one of the reasons why, looking at Taiwan, they thought about moving to their system for several years before they started to implement it. But
so it would certainly be possible for a state or a group of states to implement a single-payer system and have the rest of the country observe how that was going, and then make other decisions later. That's a choice that's up to you.
Kind of a pilot-type project, all right. Deputy Director Hadley, name me something that the federal government does really well, really efficiently. Good cost efficiency.
It's very efficient at distributing Social Security payments.
Okay. So Social Security, that's a good topic. What's the health of Social Security right now?
The trust fund is going to run out of resources early in the next decade.
Okay. Can you pick another? What else do we do well?
We defend the country.
We defend the country. But defending the country requires a lot more than just the federal government's share of it, i.e., there is a defense industrial base that has a certain role in it, correct? I mean, they build airplanes, they build ships, tanks, those kinds of things.
That's correct. And
Would the government need to own that in order for it to be better?
no, and we talk about as one of the key features, key choices for policymakers. You could have a single-payer system that operated, was administered by federal contractors, or it could be done by federal employees.
Let me ask this. How does the federal government do in the area of border security right now? There's been a lot of talk about that.
It's my impression that it is not meeting the goals of some policymakers.
Okay, what about in terms of infrastructure? There's been a lot of talk about infrastructure. How are we doing there?
It's my impression that it's not meeting the goals of some policymakers.
Okay, my friend Mr. Woodall talked briefly about budgets and appropriations. I mean, we're almost 4 months away from the beginning of a fiscal year, October 1, and we don't have a budget. We don't have agreed upon numbers, yet the Appropriations Committee is marking up to numbers that have not been agreed to. So how are we doing in the area of budgets and appropriations?
So we have often missed the deadlines for providing appropriations on time.
Why is that?
So I think in general, it's because of we haven't found the political will to find agreement.
So in the expansive world of policy, we do have the political piece of this thing with which to deal. So explain to me why healthcare would be any different. If we're not doing very well at some of the other fundamental jobs that are in front of Congress, and I would argue that budgets and appropriations is the most fundamental, then how can we expect that government-run healthcare, as is being suggested by the other side, is going to be that one area where we do extremely well, very cost-efficient, without the political implications that go with some of the other policy issues? How then can we expect that government-run healthcare is going to be a good deal for Americans?
Well, we say in the report that there are a couple of areas where it's unclear what would happen, in part because of political pressure. So, for example, we talk about in negotiating the prices of prescription drugs, that it's not clear what would happen in terms of actually exercising that power with the threat of excluding drugs from the formulary. Similarly, we talk about this idea that a single-payer system would have a greater incentive to invest in preventative services that are shown to reduce costs, but it's not clear whether the system would act on those incentives. But it is up to you and your colleagues to decide how to design the system to act and what discretion to give it, and also what choices to make for it.
In my opening statement, you heard me talk about the expected costs of government-run healthcare and how would we pay for it. And so we talked about things like, well, we could raise taxes. That's one way we could pay for it. We could reduce the benefit structure. That's another way we could do it. We could introduce co-pays and this sort of thing. So, and then I said at the end of my comment, in those 4 areas that I talked about, that likely it would be all of the above. Would you agree or disagree with that?
Well, that's, again, a choice for policymakers, but the more you spread the cost across different financing structures, the less disruptive any one of them would be.
I'd also like to ask a question about what I call the suppression of ingenuity or the suppression of ideas. I think Mr. Crenshaw referred to it a little bit, and that is in a government-run area where we have a prescribed list of things that the government would deem as acceptable or appropriate in treatment, that the impact it would have, government-run healthcare, on suppressing innovation, ideas. We talked a little bit about the provider network. We have a lot of young people today that are going off to school and incurring obscene numbers that I've seen on student debt in order to become professions. How would a government-sponsored, government-run healthcare suppress innovation, ideas, and the ability for the desire for people to want to get into the trade?
Well, this would largely depend on the set of choices that policymakers make. But if, for example, they chose to constrain costs by lowering provider payment rates, that could drive some innovation to be more efficient, to live within those rates. But if we take, for example, the context of prescription drugs, on some level, prescription drugs are a global market. The United States is the largest market that companies turn to. If the prices paid in the United States are substantially lower, they might be less likely to enter the United States market. Also, because the revenues have gone down, they might try to shift those costs to other countries by raising their costs there. But if they're unable to do that, then we might see a reduction in research and development as a result of the reduction in payment rates.
A couple of final questions. Under a Medicare for all structure, who would own facilities? Who would own hospitals?
That's a choice for policymakers. In some countries, they are private not-for-profits. Some countries, they are owned by the National Health Service.
So, and we talked about the takings issue, that if the government chose to own those, and there would be a compensation factor for the present hospitals out there, I suppose. And Ms. Banthen, you talked about the fact that you thought that rural hospitals, critical access hospitals, and I've got a couple in my district, could benefit. Can you explain how they would benefit?
Yes, because they take care of so many Medicaid and Medicare and uninsured patients today. They treat a greater share of uninsured patients than some more urban, suburban hospitals do. They could actually get more revenue under a single payer if Medicare payment rates were provided for every patient.
And then lastly, if I could just take a couple of more seconds, it was also stated earlier that under a universal coverage like this, that the likelihood is that private business out there would pass along the savings, as it were, to the employees in the form of higher wages. How confident are any of you that there will be anything left over, that the cost associated with initiating universal coverage would indeed be a tax increase on these people? How confident are you that there would be any residual benefit that would be passed along to the everyday consumer?
It really depends on the design of the system, but I think what Dr. Banthen was referring to was the idea that if they didn't have to pay premiums to purchase health insurance, that cost would be eliminated. But on the other hand, the tax increases or premiums paid to pay for the single payer system would increase.
Yeah, to me, that seems a bit problematic. But anyway, Mr. Chairman, I again thank you for the opportunity to have this hearing, and hopefully we'll have more discussions.
Absolutely. I thank the ranking member. I yield myself 10 minutes for my questions. First of all, let me thank you all again, not just individually for your responsiveness and your testimony, but also to CBO as a body. I think this report was extremely professional, was extremely thoughtful and comprehensive, and I think it will be very useful for all of us as we continue to discuss the delivery of health care in the country. So I applaud you for that. You know, I've been now involved in healthcare legislation in the House of Representatives for 10 years. Some of my colleagues on the other side, as a matter of fact, most of them have not been involved in it for that long, at least not in this body. And it's been fascinating to watch the discussions of healthcare with regard to my Republican colleagues, because when we spent all of 2009 and part of 2010 writing the Affordable Care Act, the Republicans in the House then gave us absolutely no input, no cooperation, and basically no interest, but lots of opposition. And I don't know what their resistance to trying to find a better way to deliver health care in this country was, but it was very, very obvious. Then we lost the majority in 2010, and then for the next 8 years with Republicans in the majority, we got 65 or so votes to repeal the affordable health care or aspects of it, and never an alternative proposal. I assume that they wanted to go back to pre-ACA days, and I remember well in 2009 when premium rates on the commercial system across the country were rising at 38%, where 18,000 unnecessary deaths occurred because of lack of health care, where 800,000 bankruptcies occurred because of health care costs. I suppose that is the glory days for Republicans in Congress. They're not for me. They're not for my colleagues on the Democratic side. And so, and I challenged them on many occasions. I remember sitting in the Rules Committee one day testifying, and I said, you know, there's a reason you don't have an alternative to the affordable health care. The only alternative is a single-payer system, and you don't want to go there. That's still the case. And if there had been an alternative somewhere in those 8 years, I suspect Heritage Foundation or Club for Growth or Cato or somebody would have come up with an alternative plan for delivering health care in this country. Oh, by the way, part of the ACA came out of the Heritage Foundation. And I was amused a little bit when, I forget which member, I think it was Mr. Roy, talked about, oh, the ACA, all Democratic ideas. Actually, the insurance part of it was a Republican idea that we embraced, that they opposed. It was a good idea when Mitt Romney introduced it in Massachusetts, but not when we tried to incorporate it in a plan for America. So I find this discussion very interesting, and a lot of my colleagues today, because I think we would do it too, if they got a big number like $32 trillion, that they're going to make the most of it. They spent a lot of time talking about that, the Mercatus study, which is at the cost of single-payer health care. However, they neglected to mention the report's finding that I find most interesting. And the authors of the Mercatus report said that national health spending would be 4% lower in 2031 under a single-payer system compared to current law. So while that $32 trillion sounds like a lot of money, and it is a lot of money, it was significantly less than if we hadn't made a change to single payer. And I know, kind of tried to mock the fact that we didn't ask for a score on the Jayapal bill. Well, two reasons we didn't ask for a score. One is we have several bills represented on this committee. As we have seen through your report, there are thousands of ways you could construct a single payer system, and that a score on one combination of those, which is never going to be done exactly the way it was introduced, is not particularly useful. But there have been analyses done of single payer bills, in addition to the Mercatus Center. And the University of Massachusetts at Amherst at the end of last year issued a 200-page report which focused on the first Medicare for All bill, which was introduced by Senator Sanders in 2017. Among the findings of that report, it would lower costs for people at lower and middle incomes and increase costs for those at higher incomes. Middle income families would see their net costs for health care fall by 2.6% to 14%. And I'm losing this, lost the rest of it on my phone. But it also said that overall cost of the system, and again, this is Bernie Sanders' bill, would drop by 19%. That's a pretty substantial saving, a 19% saving. Again, what we've seen from this hearing, and once again, I applaud you, is that there are so many ways of doing this that there will be an enormous matrix with a lot of different numbers on it. And when we actually sit down and try to legislate in this area, we won't be doing it on this committee. We will be considering all of those. There are a number of things that have been said today that I absolutely have to comment. It's one advantage of going last, I guess. And I'm sorry most of the members have left, because I'd love to ask them about it. But Mr. Crenshaw came up with some of the most tortured logic I've ever heard to get to the point, to the claim that, as I understood what he was saying, that people with pre-existing conditions would be worse under a Medicare for All system. Is that the way you understood what Mr. Crenshaw was saying? Did you get the same impression I did? Mr. Hadley?
It was my impression that he thought that a Medicare, the single-payer system would be worse for people with pre-existing conditions.
Can you imagine how that would be possible?
It could be possible depending on the design of the system.
Would any system that Republicans have devised be better off for people with pre-existing conditions than a Medicare for all system would be?
I don't know, it's hard to make that comparison.
So he also made the point that people under a Medicare for all system might not have access to the latest technologies and innovations. Do patients under today's system or yesterday's system have access to the latest innovations and technologies?
Some do.
Some do. Many are rejected. Many experimental procedures are not approved for many individuals. Isn't that correct?
That's correct.
That's correct. I also thought it was interesting that Mr. Stewart said that citizens don't want to change their insurers. They don't want to choose. They want to choose their insurers. And I thought that was interesting because just a couple years ago, Utah decided the people of Utah voted to expand Medicaid, and which would mean a lot more people would be out of the private insurance market and into expanded Medicaid. So a substantial percentage of the population in his state at least thought that a Medicaid system that expanded to cover more people was desirable, and those people probably don't care about choosing their insurers. With 2 minutes left, I want to dive a little bit deeper into this issue of taxes. It's very convenient to divide $32 trillion by 300 million people and get a number and say this is what it's going to cost to everybody. Is that a reasonable or thoughtful analysis of what the cost would be? Dr. Banthen, since you're shaking your head.
Sorry. No, that's too simple. There are lots of details involved in devising a tax financing system.
But when you consider the tax of the system, you're looking at somebody who now is paying their share of the premium through their employer. They have copays, they have deductibles, and those things would net out of any additional tax increase if they weren't paying it as part of a single-payer system, correct?
That's correct. When we were looking at the total burden on people, we'd be looking at how much they were paying net. But I also want to be clear that this would be an estimate that the Joint Committee on Taxation and CBO would do together. Remember, we looked to them for their expertise in tax policy.
Right. And also, presumably, we could construct and probably would construct this plan to pose an additional burden on employers, since if we didn't, we would be ridding them of, it would be one of the greatest corporate bailouts ever if we took the responsibility for paying for 160 million people off of them and put it on the taxpayers. That would be a pretty good gift to corporate America, wouldn't it? If we didn't charge them more some way.
I mean, economists believe that workers, not employers, bear the ultimate cost of their health insurance. But it would certainly save employers a lot of administrative costs.
Yeah. One final thing, Canada's mentioned a lot of times, and in a very mocking way. And I just want to share a story that I read not too long ago. It's in a book called The Healing of America by T.R. Reid, which is a fantastic look at how insurance is provided across the world. And if anyone reads it, I think they'd be envious of a lot of other places. But there was a poll done in Canada a few years ago as to who the most famous, most important Canadian in history was. And finishing by a wide margin in first place, beating out Wayne Gretzky and Celine Dion and many others, was the gentleman who invented the Canadian healthcare system. So despite all these stories of gloom and doom about the Canadian system, the Canadians are very happy with their system. Not that we're trying to emulate that to any respect.
Mr. Chairman?
Anyway, yes, sir.
Oh, that was me.
Oh, I thought someone. Oh, Ms. Jackson Lee.
I don't want to interrupt you, but I did not want to miss the opportunity for a moment.
All right, the gentlelady is recognized for 5 minutes.
Mr. Chairman, did you finish getting your point?
I was just going to conclude the hearing.
Oh, then
my time has expired.
Then let me express my appreciation to you, Mr. Chairman. I was not dilatory. I was in a markup. I apologize to the committee, but my passion for this work warranted a sprint over to this committee. So let me first of all indicate that I'm sure you've heard from our members how committed and sincere we are on the basic question of health care for all Americans. And we do that on the basis of those that we see with pre-existing conditions, for example. But let me tell you what I base it upon. I base it upon having been here as a senior member for more than 2 decades and seeing the transition of what we had to offer, and then it looks like almost 2 years of hearings that I participated in on the issue of the Affordable Care Act. I'm reminded of a family that actually took their 8-year-old to a particular insurance company's office because she had leukemia, and she could not get coverage, or they could not get coverage because there were no protection for individuals with pre-existing conditions, and unfortunately and tragically, she died. I had to listen to a mother whose son was a lawyer, but unfortunately got hooked on drugs and got hepatitis, and only wound up in medical care when he wound up in the emergency room in the Atlanta public hospital. He ultimately passed away. These were witnesses, of course, telling their stories. So I want to see a situation where we do have health care. And so I'm going to ask a question very quickly to Deputy Director Mark Hadley about your assessment of how many Americans are underinsured, meaning that their health coverage, but they have health coverage, but they still face high health plan deductibles and high out-of-pocket medical expenses. They might even face having insurance policies, which I've heard of before, that does not cover hospitalization.
We don't have our own separate number, but if you look at some of the studies that are in the research literature, it's clear that there are many, many people in that category. So for example, there's a Commonwealth Fund study that shows that there are 27% of people who have health insurance decided to forego care because of its cost.
And does that include also the high cost of prescription drugs plays a role in that?
I believe so, but we can get back to you about the specifics of the survey questionnaire that they
If you would, Dr. Jessica, why don't you comment?
Yes, the Commonwealth finds about 29% of people with coverage report having to delay or forego medical care, including prescriptions, due to the cost. The Peterson-Kaiser survey finds a lower number, but that includes people, all people under 65, also delay or forego medical care.
And that creates a burden on the healthcare system. Dr. Jessica, I'm just going to continue, and I'm sorry, I was getting pronunciation of your last name. Banthen?
Banthen?
Banthen. That burdens the healthcare system, does it not? When I say because they come sicker to the healthcare system.
If they are forgoing prescribed treatment, yes, it can be a burden.
Would you comment on the single-payer, single approach Medicare for all concept in terms of helping these both underinsured and expanding access to health care?
So, of course, the answer depends critically on how the benefit package is designed and the choices made by the Congress, but a single-payer system would provide coverage, insurance coverage for everyone. That's the key goal. And so certainly people would have coverage, and depending on the design of the benefit package, they could have fewer out-of-pocket costs that would be barriers to care.
I'm interested in saving lives, and so more lives could be saved if they had a package that worked for them. Doctor?
That's correct.
Dr. King, you're on the economic side of it. Would you care to see how that construct would work in terms of making sure that we had far-reaching health care for everyone in this nation?
It would certainly have a big effect on the economy. I wasn't sure what your question was.
I'm interested in the impact on people having health care.
So if people are healthier, they would be more productive, yes.
And I'll answer your question on the economy. If they're more productive, if there are more people in the system, if there are more people buying the product, prescription, going to doctors, I hear the issue about the economy. I would almost say that we could counter it by constructing something that would take into consideration the challenges that it might be to the economy. we're ahead of this now, we're not behind it, and our idea would be to make sure that we had everyone in it. That means healthy people would be in it, younger people would be in it, they would use it less, and therefore maybe complement and/or contribute to the system not crunching, because they would provide sort of the extra wings to the system. Could there not be that kind of construct?
Gentlelady's time has expired.
I thank you. I've answered my own question, Mr. Chairman. I think we can handle this Medicare for all, single payer, and save lives, and I yield back. Thank you.
Thank you. Again, I want to thank all of our witnesses for being with us today. Please be advised, members can submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. Any members who wish to submit questions for the record may do so within 7 days. Without objection, this hearing is adjourned.